All right, it is 5 o'clock, so we're going to call this meeting to order. This is Kittitas County Public Hospital District Number 1 for January 8th, 2026. We have an agenda. Does anybody have any changes or suggestions for the agenda? I would like to add under new business a review of some board policies. If nobody has an objection, I would like to add that to the agenda. Any other additions or changes? Entertain a motion when ready.
I move to approve as amended.
Second by Bob. Any discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes. If you've had a chance to review the consent agenda, I will entertain a motion when ready.
Move to approve.
Moved by Erica.
Second.
Second by Matt. Any further discussion? All in favor, say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes. And we are to number 4, presentations. Jonica is going to share some stuff with us. Does he want to introduce what we're doing with this first?
Yeah, I'll introduce Jonica Madsen. She's our strategic projects coordinator. So a few months ago, she brought to us opportunity for urology services, and now she's going to share a presentation then supported by Kimmy Greenwood and Amy Bloodsworth on a nuclear medicine opportunity for nuclear med imaging. Take it away.
All right. Well, I don't know. I don't know what page it's on. Is it?
It's just a handout.
It's just a handout. Oh, perfect. So you all should have a handout in front of you. I didn't go around and check what's in your piles, so hopefully it's there. But like Jason said, urology was one of the first things that came across my plate. Nuke med wasn't far after that. I mean, he started this process back in fall of 2024. So it's been a long time coming of exploring what our community. In addition to not just one cardiology provider, but now we have 4 that really kind of sped this process along. What we're looking at is a phased approach to a nuclear medicine imaging program by using a mobile unit. So what that means is what we've been looking at is partnering with Heritage Imaging. They're the partners that we used when we had the mobile MRI unit here. They were great to work with. And what they do is they provide almost all the things, the tech, the radioactive materials license, the isotopes, all the things that we wouldn't have to deal with, pay for infrastructure to be able to keep here. And they come on site scheduled as we need based on our referral load or order load. So right now that's looking to be about 1 to 2 times a week. And that's just for the cardiac studies that are being ordered by our 4 providers. So what we're looking at is starting with cardiology studies, seeing how that goes, working out any kinks to that, being able then to market this service regionally. We are kind of, and clearly we know we're kind of in a desert, so everybody has to go somewhere else. And so it's really great for the community to have. The next thing to this would be radiology nuclear studies. So then I have Kimmy and Amy both here. Their departments would share that load between radiology studies and then the cardiology studies. So what we've found is even after all of our startup costs, we're looking at being able to be financially sustainable. We're being able to have a profit even just after a few months of having this on site, which is wonderful. But then again, the biggest thing is being able to have that access for the community so that they're not having to drive over the pass or over that pass or that pass to get these studies. So what are we looking at? We're hoping it's about 3 months or so right now once we have a contract signed for DOH licensing and all of that. So we would be looking to start this service till probably April, May or so. We would need 1 PSR. That's all part of the budget that would live in Kimmy's department, supporting cardiopulm department, who would really kind of own this process. So what questions might there be?
From the board?
So this group that is coming out, are they like based on just patients that they see using their equipment, they get a percentage of that revenue, or or is it a combination of both?
Right, so each study.
Oh, no.
That each study has its own cost. So there's not a flat fee per day or a flat fee per study because it just depends on what's needing to be done.
Mhm.
But then you're right, Heritage takes a piece of that pie, and then we are able to have the rest, and we still come profit. Yeah.
They bring in all the equipment, tech,
And the tech.
the isotopes, supplies, everything. So yeah, they bring it all in.
Yeah, and that study cost includes all of that material and the isotopes and all of that. So it shouldn't be too hard to be able to bill and things for it. And we just have to hire a PSR.
Is this equipment external or internal?
It's external, so there are some photos, I think, on the back page. So it is a truck, very similar to the MRI unit. We would be using the existing that pad that was built for the MRI. It would be there. So that's essentially what the truck would look like, and then that is the interior of the actual unit that would be here on site that they would have for us. So it is it's quite nice. It's not some trashy thing, a trailer in the back of the the alley or something. But yeah, so it is external.
And it's 7 days a week, 5 days a week?
You like 1 to 2 days a week is the projected timing with the volume that we have now.
Yep.
Future, I mean, it could be much more depending how we want to market that.
Would the vehicle leave in between?
Yeah.
Okay, so it's just here for an appointment.
So it's here for that full day or that full 2.
Something that's been scheduled.
Yep, they're here for that full day. They leave, and then they come back. Yeah.
And you're thinking it'd be average like twice a week that actually come here for an
Yeah,
appointment
one-
once it's underway?
Yep, 1 to 2 times a week. Yeah.
Okay.
It's on volume.
And does this disrupt parking at all? I know it's a pad and whatnot, but
Yeah, there will have to be, and that's what we've talked a little bit with engineering about. There'll have to be some sort of, it shouldn't disrupt who can park. It's the employee parking on that side. But we may have to block it off when the truck is coming on and leaving. But folks will be able to, it shouldn't be too disruptive to staff.
My last question.
Yeah, no, please.
Dr. Jensen, what's his opinion?
Go ahead, yeah.
So he will read the radiology nuclear medicine and Dr. Nyack will read the cardiac
Got it.
nukes. The cardiac nukes will go into our cardiology PAC system
Uh-huh.
and then be read that way. And then the radiology nukes are read through our radiology PACs. So, and go through ONRAD and all
Got
that.
it.
Yeah.
Dr. Jensen's read these studies before. He's excited of the opportunity to see that we're expanding in this direction.
Yep, thank you.
How many patients could we typically see in a day?
It depends on the study, from what I understand, unless you guys have a
Yeah.
different.
So there won't be many, probably 3 to 5. Yeah.
Is that because of demand, or is that because of how long it takes?
It's length of time, plus the patients can't eat before they come in and have this test, so you don't want to run it clear into the afternoon and then have them, go without eating. So we try to do them before 1 o'clock.
And these are going to be outpatient. They're not, we're not intending to do emergency NICMED, because we don't have a hot lab in our own building. So those have to be ordered and brought to us. So it has to be really planned out.
Good.
Where this came from is I was at a cancer support group in town, and they asked me to come and just talk about imaging. And there were several gentlemen there that were just, would you please think about bringing nuclear medicine here so we don't have to travel so far for follow-up work. So that's where this was born. It was just that community ask.
Well, that seems like something we should tell people about. You're right, there's a demand from a certain sort of popular community, and this is all about sort of access, serving the community. As you say, it supports all four strategic pillars. I don't know. That's it. I love that story.
Yeah, that's a good
where
point.
that came from.
Yeah, and then the other side of it is, Amy has this expertise and, bringing in the cardiologists, keeping them here, allowing them to have full service tools, is really supportive and helpful in growing that cardiology practice as well.
Where is the nearest facility that offers this, where people are currently traveling to?
I'm using it at Forks.
Forks.
Yes.
Come on.
Wenatchee and Yakima, yeah,
That's my favorite.
yeah. And then, you probably know, Yakima, they're on strike, images, so.
Oh, I misunderstood you. I thought you meant actually using Heritage, not necessarily. That's why I was like, I'm using it there. I apologize.
So Yakima's on strike, the nuclear medicine, or?
Oh, that was it.
Imaging, and I think lab and pharmacy.
How long has that been going?
Last
week.
Days.
Yeah, we were contacted. We take students from the college in Yakima, and they're not able, their students can't go there with people on strike. So we're gonna take on some extra burden to help those students out. Otherwise, they'd be left high and dry. So
From Pacific Northwest University.
no, Yakima
Oh, IBC.
College, yep, the radiologic technology program.
And so, we have MRI and CT. What does this do? What does it capture? What's it looking for that the other devices we currently have don't do?
It's metabolic. So, say you're looking for a type of a cancer, the radioactive isotope is, it's embedded or it's traced with the type of sugar or that particular pathology would not defeat
Kind
itself.
of bond with, or
Yeah, sorry, it's really probably not the most scientific way to describe it, but so then it will show up where that area is.
so these require longer tests with a specialized device.
Yeah, so the radioisotope is injected and then time is spent, or you know more about the cardiac stress. I've done that work at Confluence, but it's been a while.
Mhm.
But it allows us to see, like for bone cancers, that type of thing, thyroid exams.
But it's overlapping with cardiology, so it must have something to do with their specialty
Yeah.
also.
Yeah.
And it's really, it's a tool for, like they were saying, so we're not having to send our patients out of the community, but for patients who can't physically walk on a treadmill and do an exercise stress test that way, or if they don't qualify doing the stress echo, this is the last opportunity they have. And if they don't qualify for like a dobutamine, which is a medicinal test as well. So then this is like their last option of having that without actually physically making them do the exercise on the test. It's done with this.
And so it sounds like once it's kind of stable and underway, it should basically cover its costs and so forth. Okay. Good.
Yeah.
And it is something that our cardiac team would like to have available as a tool.
Yes,
Yeah.
they are.
And local.
They are
Every day they
incredibly
are.
excited about the idea that we're even talking to you about it. So yes, they are very excited.
So is there anything you need from the board coming out of this discussion other than to educate us?
To educate you, I think.
Yeah, I'd just be looking for a motion from the board for administration to enter into negotiate and enter into a contract to bring this service to Kittitas County.
And do we want to hear numbers, guesstimates, or just say in short order, it'll pay for itself?
Short order, it'll pay for itself. So there's almost no investment up front.
Okay.
We have what we estimated about $5,000 of electrical work. The investment's already been done. So when we put the MRI out back, we reinforced the concrete, we put the covering on it. How we were prepping patients and doing all that with a changing room and all that stuff down there, I think is all all set and ready to go. So our investment's already been done from the.
So unlike some service lines that are a million or more maybe to get started, we don't have that sort of upfront costs.
Pretty low upfront cost. We'll want to get an additional staff member for registering.
Yeah, I think the biggest cost so far is just, to be able to start with the cardiac nuke studies, we do need to have a software. It's called 4DM, a software that the cardiologist will use when they're reading it. And so that's the biggest, cost.
Is that like an annual license or something?
And there is, yep. So I have, let's see, I'll get it for you. So the 4DM software costs $51,623. But moving forward annually up to operate after that for the annual license is only 3,000.
Okay.
So that's the biggest chunk is that software to allow them to.
And that covers the entire cardiac team. It's not like per seat or
Right.
something.
Yeah.
So,
Yep.
okay.
Yep.
Do you have anything else on your presentation you'd like to share with us?
No, I think that kind of covered in a nutshell our idea of what this will look like. So.
Any of the board members have any additional questions?
I don't. No.
But I'm impressed with that annual
Yeah,
fee
I'd
of
make the motion.
$3,000. That's practically free in healthcare.
I know,
Yeah.
right?
Erica?
Oh, she was just on. So Bob made a motion
Yeah.
and second by you, Erica. Okay. Motion by Bob, second by Erica. Any further discussion about this? So this is the motion to authorize the administration team to put together a package to offer this service as efficiently and quickly as possible and so forth. So any further discussion? All in favor, say aye.
Aye.
By two will vote aye. Anyone opposed? That motion passes.
Great, thank you so much.
Thank you for the presentation. I appreciate it.
Thank you, Jonica.
All right, moving on to the next one, we have Department Spotlight, the IT group. Jeff, welcome.
So Jeff's doing the Department Spotlight of Information Services today and is joined by a lot of his staff, Naomi, Brenda, and Tim Jennings, and see John online to support the presentation.
Yeah, Evan was supposed to be here too, but he's on a flight as we speak, so I'll do the security as well. So information systems, I'll talk a little bit about our structure. So I think we have 22 FTEs in IT. We have informatics, project management, infrastructure, support services. What else do we have? We have a bunch. Oh, security, yeah, Evan, and then HRS or HR. We have quite a few for critical access. I'm always surprised by the variation in IT departments between critical access hospitals. We see some that are as big as us, and then we also see some, I think there are some with 3 or 4 or 5 in their IT department. And so to me, it's always a kind of a roadmap or, what the organization is doing. And so I think I always say, from IT perspective, the bigger the IT department, the more the facility or the enterprise is doing, right? And so a lot of projects, a lot of initiatives going on a huge number of service lines that, and new service lines that may come up as well. And then construction and everything else that goes on that IT covers. And I'll introduce others here as well as they do their presentations. So Brenda's here to do informatics. She's the informatics manager. Tim is the support services lead, and we have Naomi, who's our recent hire, who's our project coordinator. Catherine is on medical leave at the moment. So they all stepped in to help present as well. Some of the key things that we focused on in IT, kind of our visions and goals are, we are very process oriented, obviously. I had a lot of former training in Toyota production system, Virginia Mason production systems, lean and involved. And so everything we do, we focus on process that helps us to standardize what we're doing. We have a lot of endpoints, probably 1,700 different endpoints.
Not right?
Yeah, computers that we have to manage, as well as, the infrastructure, all of the servers and everything else that we have in the background. That also helps us with change management. So any small tweak to the system can have a huge effect for the enterprise downstream. And so anything that we do, we make sure everyone's on notice. It's not done in a silo. And so communication we talk about is always key. And we always say the busier we are, the more we need to communicate. And that also helps us with our consistency on what we try to maintain and provide. As a big department, we have a lot of team building exercise. And so every month we do something. We do Blackstone cook-offs, kind of like, tailgating for lunch in the parking lot. We do that on a monthly basis. In the winter, we bring that in and we do Instapot cook-offs and some other stuff. So we do that continuously. Another big thing that we do, just because we're in the community works environment, is we collaborate between a lot of different hospitals. And so anything we do, we also collaborate with others to see what they're doing. Some of them are on our systems like us. And so two that we almost daily we talk to is either Mason General or Columbia Memorial. Columbia's on the same Cerner system instance that we are. And so we collaborate. They have the same amount of FTEs that we do. And so we collaborate back and forth with what each of us doing, as well as the rest of the rural collaborative, all of the other rural hospitals in the area. So this next year, I'm going to be the chair for the IT committee. We started that last year to complement all of the other committees that are going on. And we meet on a monthly basis. And so I think we're having an on-site meeting here in May to bring everybody from the other rural health committees over. And then something that we were part of, and we just will have our first virtual meeting, is we call it the Pacific Northwest Regional User Group, PNW RUG. And this is for all of the organizations that is using Community Works in the Pacific Northwest. So Washington, Oregon, and Idaho. And so we'll do a virtual meeting here in January, and we'll probably do the first on-site visit. So hospitals coming here probably in the summer as well. So kind of highlight not only the hospital, not only IT, but everything else that we do here as well. So being one of the larger, and staff IT departments, our goal is to help others as well, right? And so help others with our knowledge and expertise, as well as some of the resources as well. So a lot of collaboration that we do. Other things that we've done here, and so I always say we're kind of in a dichotomy of very old technology, things that we're trying to rebuild from an infrastructure standpoint, to also implementing some of the new latest and greatest, whether it's AI or some of the other things. So we have both ends, and we've been working tremendously over the last probably 7 years that I've been here to read a lot of the things. And so I just wanted to highlight this. This is, I see John on, so this is, something that John does behind the scenes. And so this was from 2018, and these are our data closets. And what it has progressed into what we are doing today, which is on the bottom. And so this is 7 years of work that is done. No one will see this, right? For the most part, but what we do in the background. And this is more visual, but this is also for all of the other IT things that are happening in the background.
Was that a fire in the top left?
Just about, right? Yeah, and so all of our net new closets, especially in the expansion area, look like the bottom now, and are very clean. And we'll be, as I talk about, we'll be moving our data center off the roof to one of the other locations down here. But that was all in preparation for a lot of these as well. So it's a lot of work behind the scenes. I have a printout of this because it was too hard to see on screen. And so this is, you're getting a sneak preview of our copy for 2026. We're calling this, digital health optimization. Brendan will talk about what we did in 2024, and 2025, on her next presentation. But for 2026, we're calling it digital health optimization. What we're doing this year is not only focusing on our EMR and Cerner or Oracle, we're also focusing or bringing up front some of the other things that we're doing, whether it's infrastructure changes, so the new location of our data center, and also all of the cyber security program that we're working on to what we currently have, as well as a lot of the other projects. So whether it's Janine's UKG, and some of the other implementations that are going on, we're kind of putting it all on a timeline. So basically, as you can see, 26 is full for IT.
And the stuff in green, the left third of the screen, is all 2025. Has that stuff then been completed?
Yeah, so the green, if you look at the ledger, the green is, I think it's, those are already done.
Okay.
And we're kind of just progressing through as well. Yep. I'll have Brenda talk a little bit about informatics, and just because within the 24 and 25 copies, our strategic plan, informatics was a key player in building all of our platforms with Cerner and Oracle.
Currently, informatics structure, there are 9 employees, including myself. We have 2 trainers. Stacy Botten, who is in the clinics, working specifically with providers. Our hospital trainer has moved to clinical excellence. So the hospital has gained a gem and they will be benefiting from her being there. And we are looking for her replacement. I have staff that's separated either clinic or hospital. We also have interfaces. We have ancillary departments. Kristen Shaw does all of our ancillaries, lab rad, nuke med. Now will be one of her. I know she's been working already in the background on that. We have Tara Preciado, who is our newest, that is in cycle and has been a joy to work with. And she has so much knowledge that she has saved us as we've moved to SSI, as we went through now I'm going to lose the name, when our system was hacked, not our system, but
Change
Healthcare was hacked. She was instrumental in getting us moved to another system away from them so that our data was not to be compromised
Keeping cash flow.
and keeping cash flowing. Yes. So fantastic team. If you see them out and about, give them a shout. 2024 to 2026. My staff has been more than busy. We initiated in 2024 with the provider optimization, which was a one-on-one with an Oracle staff member that we went one-on-one with 26 different providers. We spent all day with them over a month. And so they got us once a week and we worked through all of the providers to help look at their workflows, to help optimize, to help them work so that they didn't have the pajama time. We still continue to monitor that and are seeing significant improvements. I wish Dr. Thomas was here. We then let
That was perfect.
Perfect. You were hiding outside at the door.
I endorse significant improvements.
Yes. And to add to that, we have been added clinical AI assistant, CAA, you'll hear providers talk about, which allows them to go into the room. They take the phone with them, they dictate, their note is done while they're in the room with the patient. We have 40+ providers that are currently employed in the clinics on that. And we have 3 providers that have been deployed for 2 weeks in the ED. So we are starting to move that functionality into the ER. It also, I believe, Dr. Thomas has decreased the number of documentation deficiencies you're seeing.
It's very much a team effort.
Yes.
Good hard work. Thank you very much for your contributions to that.
Yes, and so we try to support helping Dr. Thomas not have to do so much work also. We also in 2024, 2025, the clinic separation. During COVID, we added many service lines. And to do that, we ended up building them under other clinics. And so FME had women's health, pediatrics, rapid access, all built under their clinic. And so we separated all of those clinics that were built under other clinics during COVID. Our cardiology clinic was under internal med. Our neuro clinic was under internal med. So we separated all of those, which made Scott much happier because financial reporting is much easier when they aren't buried under another clinic, which took a lot of work from the staff. That allowed us to remove all the extra rules and to get the GLs and the financial reporting in line. We added in 2025 infection control that is allowing quality to be able to report directly to the state. It's still in the works. I know Anna was loving it.
Anna's going on vacation tomorrow and she's not worried about notifications. It flows directly from lab results now and pops up the isolation and the protocol. So it's been incredible.
We
love it.
And so we've freed Anna up a bit because originally all of this reporting was done on paper and she had to write it all down out of the chart.
On the separation project, I just want to mention from the patient's view perspective, now they'll get a bill from KVH orthopedics rather than FME. Or for cardiology, they'll get appointment reminders for cardiology rather than internal medicine. So
Yep.
it was very, doing that breakout really helped the patient's communication.
Right. And then it allowed us to move into UCC, which is Unified Consumer Communication, and Artera that sends our patients multiple appointment reminders. When they schedule their appointment, it sends them a reminder that says, you just scheduled an appointment for this date and time. So it reminds them that you've been scheduled and it will go out and reach out to them 7 days before, 3 days before, and then 1 day before. Remind them that they have an appointment. They have all those multiple opportunities to say, I can't come, which then communicates back to the clinics and will, I believe, has helped with no-show rates. And so we are helping with the clinics get their no-show rates down and better communication with the patients because they can actually text with the patient through Artera, which is HIPAA, and allows us to keep all of that private, but lets them communicate.
Has it reduced any calls? Have we seen changes in that?
Not necessarily calls, but it has significantly improved no-show. So FME just had their all-staff meeting and their no-show rate for December was 8%, and they've always been double digits. And I think overall, the organization, if you lump all the clinics together, we're probably sitting right around 4% no-show rate.
Which is significantly better than I think it was a year ago. Yeah.
The other piece to that too was on the no-shows. Now, if they say they can't make the appointment, it clears them off the schedule. So
It actually cancels. Before the reminders, if they said they couldn't make it, it ended up going nowhere. Now we get a cancellation and we actually run a cancellation report. So then the patient service reps go through that and scan of, oh no, this person really needs to be seen. We'll get on the phone, call them and say, we noticed you canceled your appointment. I probably would like to still see you. Let's get you rescheduled.
Does it also make those openings available for people waiting? to
Yes,
see provided?
it will automatically remove it from the schedule, so they're available online for people who are using online scheduling, and then they're available for the PSRs to schedule.
We have also moved forward with SSI, which is a revenue cycle management. we had moved to Trizetto with the Change Healthcare debacle. We moved there quickly. It wasn't our choice necessarily. And so SSI is our next step in revenue management and allowing for the AI add-ons that Oracle is working on, which will benefit coding, billing, all of that. Plus it is improving our statements and our messages to our patients. We've recently completed Seamless Exchange, which allows us to get records from Epic, from Waze, which is our immunization program. They pull those in, and then they can be incorporated into the records. So you get all of the patient's immunizations. If they were seen at Memorial, you should be able to pull their records in as long as a sign for those records to be released. So it's making really nice for our providers to be able to see the extra things. We are working on acute case management, which was on our schedule 1. We didn't have the care managers then that we do now. So it wasn't built out fully. We're currently working on that functionality for our case managers and utilization review. So that one's coming. Podiatry urology is going to go live on Monday. So we have the podiatrists. We're working on the urologists. We're getting there. Q2, Q3, we're going to be doing patient portal upgrade, which our patients will benefit greatly because then we can also use Flywire bill pay, which will allow them to manage their accounts better. They can actually schedule payment plans, things like that right online, which will then reduce calls to our financial system.
And one bill.
And one bill.
Really?
Oh,
One piece of paper in the book?
Bill, nice.
Per week. And
Per week.
information will be required to pay a bill online.
Sorry,
How many pieces of information are necessary to pay a bill online? Like,
they log into their portal
and
and they can access their bills from there.
Will I be required to have my paper statement and enter an account?
No,
And when you pay it, it's real time back to our side to notice the difference.
Oh,
because I recently tried to pay a bill and it refused my credit card, refused the next credit card. So I went to lunch. I didn't know what to do. I really wanted to give you money, but it refused to take it. So I don't know.
the next big thing that we really push for, and we're looking probably the end of 2026, is for CareAware, which will allow our nurses in real time to document on the floor with a device in their hand. They can scan a medication with it. They can scan an IV and the med, and it will set the IV pump for that medication. They can scan the wristband with the same device that they're entering their charting on. It will forever change, you know,
Let's get going.
the nursing world and what they can do. So that's what's up and coming. Just to give you an idea of some of the other things that my staff are doing is they have created, it's called Learning Journey. It allows us to have a very consistent training for every single MA, for every single PSR, every RN, every provider. They see the exact same education. Well, all the providers see the exact same education. So we make sure that we have consistency across the board. The learning journeys then, depending on your position, you will come in and have in-person training also. So after completing the learning journey, we go through it, we walk them through everything, ask any questions that they might have. MAs, clinic nurses, they get an hour of in-person. Clinic providers are 4 hours. And then our providers also get at the elbow days, 2 to 3, depending on the provider. Sometimes they get 1 and they go, I don't need you. So, but we offer them as many as they need. Total training hours, just for in the clinics, 437 hours in the last year. This is just rounding. This started in May. Ellen was rounding at the hospitals. She spent a total of 89 hours rounding with nurses so that, just touching base, seeing if they had questions, seeing if anything was going on. Providers were 28.25 hours. So she was touching bases with the hospitalists, the ED doctors, making sure they had what they needed. Any questions, any issues. So that has really helped with getting everyone where they need to be. And just for clinics also, they were doing rounding. District 1, so all of our clinics here, they spent 434 hours rounding, touching base with providers, documenting every interaction and how long it took. The advanced patient letter was something that was newly rolled out. So they spent 2 hours going around touching base with every single provider that they knew how to do that.
So is the idea that they say, I need it to do X, and it's not doing X, how can you get it to do that? Is that what happens?
Sometimes that's what happens. Sometimes it's, how can we help you? What are you having trouble with? Anything like that. New functionality like the continuous or the advanced patient letter. We went out and personally helped every provider set up their new patient letter. Because it had to be done per provider. Couldn't be done on a global setting. And so it's that touch that making sure that the providers know they're supported, know that we're here for them. District 2, 354 hours. So we are making sure we are touching everyone. Anyway, I'm going to pass off the clicker. Thank you.
Thank you.
And I'm Tim or TJ. I've worked with everyone before. You all know me. So I'm just going to talk about what the help desk does and the kind of volumes that we see. So total number of tickets that we saw in 2025 was 14,741. That's it's palindrome. It's anybody, number person like me. And just over 8,000 of those were support services, which is my team. There's 5 of us. We're the first line, and sometimes we're the last line. Sometimes we have to escalate. So we're the ones that answer the phone. We're the ones that get the email tickets. We're the ones that meet people in the hallway. We're the ones that sometimes see people at Fred Meyer and, start the ticket process. So we handle the majority of those tickets because policy is if we can handle it on first touch, we will handle it on first touch. If it's not necessarily our ball of wax, we mostly handle the stuff that people can touch, the mouse, the keyboard, the actual computer, that sort of thing. But once it goes past that, sometimes it's others. But as we go along, we learn. If we escalate something to say the network guy, and he goes out and figures out what the problem was, comes back and says, hey, next time this comes up, you can do this. And then that way, the next time we can get it solved on the first phone call. So that's always our goal. Informatics, 4,332. That's, mostly the tickets for problems that are specifically either with Cerner not working the way it's supposed to, or needing some sort of education or some sort of addition or, adding functionality, that sort of thing. The security 998, that was mostly phishing tickets as we send out our monthly education. And people, submit those things, and Evan has to take a look at those and find out so if it's actually a test, as soon as you click the button, it says, congratulations, you passed the test. If it's not a test, then it's actually something that Evan has. And that's what those 998, that's when people looked at something suspicious, reported it as being suspicious. Evan took a look at it and then decided to either, it isolates the email, and then he looks at it and says, no, this is actually fine. And then he can send it back to their inbox, or he can say, thank you for reporting this. This is actually dangerous and good job. So
Do you know approximately what percentage of those 998 turn out to be real versus this is okay, you can go ahead and.
I don't.
Okay.
Because I'm not the one that handled. I was hoping that, Evan, he had unexpectedly had to leave town, but So I don't know how many of them are, but I expect it's probably half and half.
Part of that will be in the other part of.
Yeah, and there's some security slides open up that'll maybe address that stuff. And then 959, 58, that's telecom. So it's any problems with any desk phones, fax lines,
Mobile phone.
mobile phones, iPads, the home health tablets, all of those come under that. And then other, which is all of our infrastructure, and the other support departments is the 458. So here's a nice little pie chart that I did. I ran a report. So you'll see on the left side, the gray pie slices are all other. And then the colored slices on the right side are the top 10 issues that we dealt with throughout the year. So you can see that get a little closer. 19.5% was Cerner related. So the stuff that these guys handled. 7.6% were passwords. So that was our second largest thing, where somebody forgot their password, they changed their password, they couldn't remember it. That's our biggest thing. And a lot of that has to do with the fact that it's harder and harder to integrate Active Directory authentication. And so we're working on that. We're making improvements on that. And so that's great. Then 6.9% was general hardware issues, which could be, anything from a new computer, replace a computer, fix a computer, but actual something hardware printer. Then we have broken out later on. And then user accounts, 6.8%. So that's new hires, role changes, name changes, terminations, that sort of thing. So that was a very large number. And then under software, Microsoft in general, we had about 4.3%. So that's anything that's Windows, Office, Outlook, all of those things. And then phones, 2.9%, printers, 2.4%, peripherals, 2.2%. That's keyboard, mouse, welcome tablet, those various things that plug into the computer. And then email, 2.2%. That's mostly problems with calendars or with the email not working, email being lost, trying to figure out how to recall an email. And then the last category there, which the text rolled off of, can't remember what the category was, but yeah, it was the lowest one. Oh no, that one was actually just specifically Microsoft Teams. So calls that came in about Teams not working, that people not being able to communicate. So this is an example slide from our daily huddle. So every day, Catherine, now Naomi, while Catherine's out, pulls the stats out of Case, which is our help desk system, and puts this slide in there. So it says the total number that were opened, total number closed, those that have not been assigned to an individual tech. And then in informatics, they have everybody's, how many informatics as a team closed, how many are workable. That means they're things that can be worked on. They're not waiting on a vendor. They're not waiting on, a global change. There's stuff that, certain things we can't work on because it's out of our hands. And then the total there. So you can see each one of the, how many they closed that day and how many they had left in their queue that were workable. And in support services, again, the largest numbers because we're the ones that answer the phone and have people come knock on the door. And then we keep count of the total number of users each day, and then infrastructure and other. So now
I'm Naomi, per diem project coordinator, filling in for Catherine while she's out on leave. I started here end of September as an intern, and I enjoyed my time here, and it just seemed like a perfect fit. So now I'm filling in for Catherine. Tools that we use, meetings, we do weekly project huddle meetings, and then we also do project specific team meetings to go over project plans and everything. We also use structured processes for new project requests, like Jeff emphasized, standardization. We want consistency. So the process for new requests looks the same. The request will be submitted. From there, it'll be reviewed by the executive team. It'll be approved for expiration. From there, we'll do demos and calls. These will be clinical functional demos, IT tech calls, security calls, third-party risk review management. And then from there, we'll do vendor choice. That will go to that'll be a regular capital board process. And then from there, we'll begin the project initiation and continue with the project process. We use Smartsheet as our project management software. The primary use is project plans. Other uses, cross-functional department, emergency preparedness, safety committee, and hand hygiene are some examples of how Smartsheet is used cross-functionally among the departments. Many departments use it. Many of the clinics, lab, we use it. So it's used quite a bit. It's used for workflows, again, new requests, stuff like that. Department huddles, like TJ just showed that slide with all the ticket information. That's a dashboard from Smartsheet. So it helps communicate information quick and in easy to understand way. Here is a dashboard for Smartsheet usage within the organization. We have just over 3,000 apps and spaces currently. We have 61% of those are project sheets. This is kind of where we track our projects and everything. 144 of those are workspaces. 861 of those are reports, and 200 are dashboards. During our weekly project huddle reviews, we'll go over move requests, cover large complex projects, standard smaller projects, and then new requests that are coming in as well. Project stats for 2025, we averaged 8 to 11 in motion large complex projects, and we also averaged 18 to 25 standard smaller in motion projects as well. All right, here is our executive project dashboard. Use this during our weekly project huddles as well as our monthly department meetings. The top communicates kind of our bigger projects that are going on, any projects that are finishing up in the next 60 days or any ones that are overdue. Right now you can see we have 8 that are green. That means they're good. Those are 8 large in motion projects. Below we have the small in progress future on hold projects, and the pie chart on the left is a breakdown of where the projects are coming from in the departments. The bigger slice is information systems, and then you can see there's ED on there, cardiopulm, clinics, imaging, lab, so lots going on. And then on the right, the pie chart shows how many projects that we have that are smaller in motion, how many are approved, how many are pending approval, how many are on hold, and how many have future or potential to go forward. So a great way to communicate information quickly to the team. Continuing on to that executive dashboard, here's our projects completed information. In 2025, we completed 45 projects, which is significantly higher than the amount we completed in 2024 at 26. And then you can see kind of, if to the right, it kind of shows where the departments those are being completed at. Yeah.
Yeah, I'll cover this. It's Evan couldn't make it. And so this is kind of our cyber program as we've moved forward. This is our phishing dashboard. And so something that has changed fairly recently since May is, so we were ranking really well at about 3% on our phishing tests, and that's every month we send out a phishing, email. What has changed is in May, we started to do or introduce AI into it. And so now the system is learning from the phishing perspective, every user, what they like, what they tend to click on. And it's implementing that into the phishing tests as well, which is what the bad guys are doing as well, right? So what you can see is we did have a spike in the higher spikes are all of the AI phishing tests. It's called ADA. And so we are currently at 6.7%, industry standards 4%. We were down in the standard phishing, we're down to less than 3%. And through, time and training, we'll get back down again, as we move forward. So I remember the first phishing that we did when we started the program, it was a baseline. So no one had seen a phishing email before. I think we were at 28% on that first baseline. So we continue to train, and we'll move forward with this, and we'll get it back down to below industry standard. So this is email security. We introduced a new email security appliance that's a little better than our last one. And so this is 6 months worth of data.
It's been a lot better.
Yeah,
It's been a lot.
it's noticeably. And so I don't have to click on or screen out any emails anymore. Yeah. So this is just an example. So in 6 months, we had 4.3 million emails hit the system. Out of that, we have various different filters that it goes through. And so, long story short, at the end there, we had 933,000 emails that were actual emails that came to us. So about 80% of the emails are totally blocked. You don't even see it.
That's external emails coming in.
It's just external emails coming in.
And we let just under a million.
Right.
Yeah.
Yep. Yep. And then things that we're doing. So we scan on a monthly basis our vulnerabilities. And so this was back in 2022 when we started this program. We had 41,000 vulnerabilities through the system. And till today, 25, we have 11,900, and which is actually for us, it's a zero number because these are all the new threats that are coming out. So as it scans, we go and clean them up. We prioritize which ones we, activate into our systems and which ones we don't. So this is basically, we're up to date now on what we're scanning in our vulnerability. So that was a lot of work within the last 3 years. And this continues monthly. We have a monthly meeting on this as well. And then quickly, this is our cybersecurity timeline, and basically our program or our footprint. And so things that are in blue, we've implemented. And so CrowdStrike, so every endpoint that we have, every computer is being monitored 24/7. And so it knows whether it has suspicious activity going on, not only by us, but by an outside company. And so whether it happens, 2 a.m. in the morning, and it sees some suspicious activity on that endpoint or, laptop or workstation, it'll alert the company as well. And so if it's something serious, they'll basically shut it down or they'll take over as well and stop the threat if needed. We get alerts all the time on what's kind of happening. So if I know if Jason, they see that Jason is down in surgery on a workstation, which is not a normal pattern, it knows it and it flags us that something suspicious out of the normal is happening. And so that's 24/7. The bad guys tend to pick holidays, 2 a.m. in the morning to deploy out some of the ransomware and other things. And so that's why we have this kind of 24/7 monitoring. Other things that we do is we introduce, multi-factor authentication, which is, basically required now by every cyber insurance company if, you want to be covered. And it's good for us as well. So that is deployed. We not only scan all of the emails coming in, but we also scan and know all of the requests that are going out. So if someone in the inside, Googles and clicks on a link that they want to, look at some certain thing, we know whether that's a threat or not. And so those have been blocked or will be blocked in that transaction as well. So it knows, basically the bad actors, the bad sites, and it'll prevent them from getting there as well. So data loss protection, we also have to know where our data is going. So if someone happens to download patient information and send it off somewhere, we know we know that. And so we were able to block that as well. And let's see, we're up on email or password. I think we're 15 characters right now. So we are at standard. The ones in green are also our monthly scans. So these are things that we do on a monthly basis. So whether it's the vulnerability scans I talked about, whether it's the phishing tests we do, and then the AI tests, and then the yellows is things that we do on an annual basis, whether it's our security risk assessment, which we just did one. I think we have the draft. We don't have the final report yet. We do pen testing on an annual basis. And so that's where a company spends an entire month trying to break into our systems. So they're on the outside. They act as if they're bad actors trying to social engineer what we have publicly, pretend that they're employees. They'll do everything the bad guys do. And so and try to get into our system. They'll even do phishing and vishing scenarios. And so they'll call at 10 o'clock at night and pretend they're a provider, like, hey, can you my password? I can't get in. And so they'll test our systems and our staff, whether that we allow them to get in or not. So
You said vishing, is that portmanteau voice?
voice, yeah, and smishing is texting, right? And
What
so
was that?
vishing or smishing, smishing is texting, and vishing is voice.
Okay.
Yeah.
Okay.
Yeah. Besides phishing. Yeah. 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 And so that was done just recently, and so they were not able to get into our system this year, so which was great. And it was fully tested. And then the other thing that we do on an annual basis is we do some type of incident response plan. So last year we pretended that we were hacked. From a tabletop perspective, what do we do? This year we're going to go a little deeper, and we're going to be hands-on. So we're going to pretend that we have been hacked, and we are they downloaded ransomware so we can get to our systems. And how do we back up from the current things that we have? And so how do we recover from that? So we'll do a little scenario with that as well, probably in February, I think. So, any questions? Sorry, we had a big presentation.
Busy.
Yeah. Any questions?
No, you guys just touch every corner of the organization services that we provide to the community. So thank you for.
Yeah.
Anytime we have any glitch or hiccup going on, these guys are always at our call day or night. So thank you.
Yeah, you're welcome. Yeah.
It's often seamless to the patients and our customers.
Yeah. The other piece, from our structure as an org, there are a lot of others also that are also managed or contracted out IT services, right? And so I'm happy to say that, all 22 of our staff is here. And so that's a big deal.
It's a huge benefit to us. And it's our staff serving our community when things go out there here in the middle of the night, when we had the Change Healthcare.
Yep.
Our whole team came in and went through every single computer and touched them all, and you can't do that remotely or with contracted services.
Great.
Yeah.
Thank you.
Thank you, Jeff. Appreciate it.
Yeah.
And so for those that gave presentations, feel free to head on home if you don't want to sit through the rest of the board meeting. It does not hurt our feelings at all. So we appreciate you taking the time to come in tonight.
Yeah, welcome to stay too.
Yeah, definitely welcome to stay, but thank you for your time.
Thank you, Tim.
Jeff, on those phishing emails, I wonder, you said the percentage kind of back up a little bit with the AI involved and whatnot. Would it be useful at all to send an email to all the staff and it says, in the next few minutes, you're going to get a phishing email. And here's some things to look for. And a couple minutes later, it pops up and you tell them what to do, identify these things, then click, this is a phishing thing. And do that a few times over a month. So you're helping them understand what to look like and get out of that loop of, oh, it's an email. Oh, I want a prize or whatever it is that they're clicking on. And then at the end of that process, you send an email that says, okay, now in the next week or so, you're going to get one. You're not giving you this 2-minute warning or whatever. It's going to randomly pop up. But I just wonder if you can switch that mindset a little bit, that they become kind of much more aware that anything that comes up that you can't easily identify as coming from in-house, they just raises their suspicion. It just feels like we just kind of hit a block where we can't get past a certain amount of people that just click on things that appear in their email.
And I have reports as well in the background that tell, you can look at every individual organization and see what they've clicked on and other things as well. But yeah, that's just suggestions,
just ideas
for us. Yep.
Well, again, thank you for the presentation. And one thing I wanted to do was touch base with everyone here, board members and admin and whatnot. So a year ago, we kind of started this process of highlighting something every month in this spotlight session. I just wanted to see if there's any feedback. Is it working for people? Is it helpful? Is it, is there anybody want to give any feedback on the last year's worth of presentations and going forward? Is there anything we should do different or that sort of thing?
I think it's great.
I really enjoy it.
Yeah, I like it.
Yeah, I like it too. Good. On the admin side, does it work? I mean, is it just put extra weight or, work on your shoulders that is frustrating, or is it fun to be able to show off what you do a little bit and stuff?
Love it.
Oh, I love it. I like it too.
Yeah,
That's
Really help.
Just some work prepping the presentations, but it's also a really good process to go through. And I think that staff learn a bit too as they prepare presentations. It's good experience to give a presentation. And it feels good to be able to brag about the work and share the work that's often done behind the scenes that nobody sees.
Good. Well, it's wonderful. Yeah, I know. I certainly enjoy it. It's very educational. So I appreciate everyone taking the time out of their day to prep it and come present it and so forth. So
We have 2 spotlights for the next board.
do we? What are they? What, you want to tease us with the highlights?
Nope.
Okay.
Surprise.
Have surprise.
Oh, February's.
Wanted to mention in addition to, internally us enjoying these spotlights, that anybody who tunes in or happens to be part of the community can, get an insider peek onto what we're up to as well, which is pretty neat.
And Crystal will be using the content too to help promote our programs and through the community relations avenues, us taking the information that we get from here and sharing it more widespread.
All right, moving forward, we are to public comment and announcements. So if anyone here would like to make a public comment or an announcement, this is your opportunity. All right, seeing none, we will move forward to reports and dashboards. So Mandy Olson, we have quality.
So my report starts on 18. And we talked about this at the last board meeting, but I just do want to highlight that we are ISO 9001 certified now. Very exciting, and working with Crystal to celebrate that across the organization. It's been a 4-year-long journey, and it's something to be really proud of. It goes above and beyond accreditation with CMS as a critical access hospital, and so I'm really proud of that.
So how common is it for a hospital of our size to get that accreditation?
Actually, there's quite a few in Washington State that started that journey. I recall Pullman, I think, was one of the first I knew of that.
So it just takes that internal initiative to.
Yeah, and the Joint Commission was like the only game for years and years and years. And DNV, I can't remember the year they started, but it's taken a while, I think, for people to recognize. They have a different approach, but I know for myself, it feels completely different having a survey with them than the Joint Commission. And I really think they've helped us improve and have an improvement mindset to the survey process. Questions about ISO? I do have an update on the rest
illness season. Anna does weekly surveillance about all kinds of infectious diseases, but in particular, we do report to the health department each week about respiratory illnesses, and we have had 7 influenza A hospitalizations to date in this flu season. What we've been seeing too, when we've been doing testing, viral testing for upper respiratory infections, is about 26 to 32% of those tests are coming back positive for influenza A. Of the people we're seeing positive, about 10 to 20% of those are immunized that we can see. So we do know there was somewhat of a mismatch this year, but still that's decently low. Most of our patients we're seeing at KVH are coming, they started out coming to rapid access is where they were getting tested, but we're seeing it more in the emergency department now.
And so when they're hospitalized for this sort of illness, it's primarily a breathing issue. Is that the main reason why they're hospitalized?
Yeah. Yeah, I don't think we've had anybody septic, but I know. Yeah. Yeah. Yes.
Are we seeing it across age groups or mostly?
Um,
Groups?
So Anna did comment on that to begin with, we were seeing mostly less than 17 years of age. Now in January, we're seeing it go to more 18 to 49-year-olds. So cases are starting to increase for over 65. So hopefully we won't see that impact admissions. And so far we haven't seen it impact long-term care facilities. Yeah, so definitely seeing more GI symptoms with this year's influenza cases.
So in the news lately, there's been all this stuff on reducing number of vaccinations, following the Denmark model, whatever that is. Was this a shock to you, or has that there?
Well, I know Anna at least has been nervous about changes BC would make for some time.
Yeah, okay.
So I know in our state, there was a message that just went out like from the middle school just the other day saying, guess what? TDAP's due for 6th graders. So I don't think our state is making any changes to their pediatric immunization protocols that are required for
We all look like we're from Denmark.
We do. We should do a thing. Yeah. So I think our state may
Carry that.
what it does, right? But we have our own,
Western State Alliance or what they call that.
Washington, Oregon, California follows the same kind of protocols for that. So I don't know what it'll mean long-term for coverage for our kiddos and when they're coming to our clinics to get those immunizations.
It's not anticipated at this point that any of the Washington licensed insurers are going to change their coverage.
So, but I think we're all kind of waiting to see.
Yeah, interesting how it hit the news before anyone else in healthcare knew about it. Like,
I think that's the only updates I have unless I have questions.
Questions for Andy?
What are the implications that the C. diff case that looked like it was pre-existing, but when we,
So those are some of those things that directly affect our star rating.
Okay.
So that hospital acquired C. diff is the one measure within the, trying to remember the category in the star ratings.
Safety of care.
I can't remember off the top of my head. But that will impact that particular measure. Those are the cases. And so that's the importance of having protocols as far as when you're testing for C. diff and that you're doing it on admission if you're having those symptoms.
to disown responsibility.
Exactly. Yes, right. So they've been working on that though. We got reflex testing now happening in the lab
So when a test is positive, it's automatically doing the testing for the toxins, because you can be positive for the spores in your stool, but not be infected. So that's one thing that's been improved. And then working with the nursing teams about and identifying patients that really are appropriate for testing. You don't want to test someone who isn't really as symptomatic as you'd expect them to be for CETA, right? So I don't know if we want to talk about this here, but you really want to have a certain number of liquid stools.
Okay.
You should not be testing solid stools.
Okay.
There's guidelines around that.
Yes, and so we need to get that in place and make sure that we're not inappropriately testing folks.
Forward to reviewing the minutes.
Only thing I'll add to this was the QI Council meeting. We had several reports on patient safety measures, which were really informative. I'm always really impressed by how just all this work being done, you know, all you see is the tip of the iceberg in quality, and there's all this work being done at the granular level on all these different sort of patient outcomes to make sure that that we sort of get the highest quality care for people. And I'm just always really impressed when I hear about that at QI Council. You guys are just getting sort of the kind of surface level summary here, because you know we do that now, of course, because some of that stuff is sort of privileged and we can't be sort of publicly reported. But anyway, I just wanted to mention that to the rest of the board that there's a lot of work being behind the scenes. And I know that Mandy would be happy to walk anybody through that stuff if you'd ever like to see sort of what goes on at the granular level. I get that stuff all the time at QI Council, but it's very impressive.
Well, I think it's been some time since I oriented all of you to quality, where we did sit down and go through a lot of our systems and the different measures we have. So yeah, I'm happy to meet and talk with anybody anytime.
Anything else for Mandy? Thank you. So moving on to CEO, Jason, what do you have for us?
Thank you. I'll just run through some of the highlights on my packet, but I'm sure you'll hear it from others as we go through. So take a little Stacy's thunder. She's looking forward to opening podiatry starting on Monday. So we have a small number of patients, being 31 scheduled on Monday. That was Dr. Cardin's lighter load that we talked him into doing for his first day. But really excited for that program, and thank you to everybody that put effort into that. It really started with Jonica working through a lot of the feasibility and how to get this program going, contracting, and then space, and Jeff's team with project management. So a lot went into this. We built the Cerner shell beforehand, so they will get equipment for podiatry. They'll get a bill for podiatry, not general surgery or any other. So thank you for the IT work that went into that. Midtown Depot, Rhonda will probably mention, should have a move-in date the end of February. And then Radio Hill will start a new project meeting, probably with Naomi, to do a project meeting every 50 weeks to get that going good soon, and then see that project through as well. Lots of stuff going on for new stuff this year. We had 26 provider offer letters accepted last year, so stole from Dr. Thomas there probably. And I went and talked to our HR recruiters that they have to reset their numbers, so it's 0.
That's all right.
I'll let Holly speak to all the work that she's doing in nursing leadership there, but really nice to have her. When she started, she was able to jump on the last 2 WCNA negotiations with us and see that through the finish line with the team. So thank you, Holly. Under that workforce engagement, I want to talk a little bit, and you have a handout at your desk for a policy on dependability and readiness for work. So we intend to roll this policy out. It's been a long time coming. We've been working with our union reps over the last 8 months to develop this policy. And then we had to work with WSNA negotiations to be able to implement this policy as well, because we used to have some language in the contract that we did not have any enforcement in attendance. So in short, the policy here goes through steps, we have 8 steps or 8 occurrences for warnings for call out, no shows, tardiness, and that kind of a point system and reminders, conversations and steps as people work through the expectation to be here for work and ready to work on time. We do have a pretty chronic problem with call out and people being late for work. We did a poll of other hospitals and we're the only hospital that does not have a dependability readiness towards policy in place. So this has been a long time coming. It's been work.
Say that.
Yep.
Say that last point again.
We're the only hospital that we could find that does not have a policy on dependability readiness
Oh,
at work.
okay.
We worked this through the hospital staffing committee and they were extremely energetic to get it implemented. But I wanted to come here and board to see it as well, because I would anticipate some pushback as this becomes implemented. So people will want accountability unless accountability is then. So, but we look forward to having this overall, and it will really help our staff, who are those ones that are always stepping up to take those call outs.
Is there anything you need from the board regarding this policy?
Nope, just recognition that we'll be putting this policy in place. We anticipate by the middle of January 16th. Anticipating, and between now and then doing some education with our directors and socializing it with staff.
And this doesn't bump up again at all against the bargain contracts?
No, we worked through it with the contracts. The contracts do have to follow our policies, but there was in WSNA's contract a specific call out. Attendance we could not hold any accountability for attendance, was previously in the contract.
So that's not the contract anymore.
Correct.
Well, yeah, just to clarify, it was associated with SIP. And so what they didn't do is it's a very broad definition of what SIP. And what we did with this contract was we said, okay, we're going to narrow that to protected state or federal leave. So it has to fit that protected criteria, and anything outside of that, we're going to go ahead and run that against an attendance policy, which is normal. That's the normal thing to do.
Yeah, we do have, Polly has the stats and Stacy some stats of call outs. They're really high numbers on some individuals. 30 can be common in a 12-month period, 40 up to 70, 80.
Over the holidays, we had 8 MAs and 5 PSRs that all call out on one day, on top of all the PTO we had approved off. And when I was tracking it, it could be anywhere from 320 to 400 hours of PTO, sick time, extended leave time, every pay period for MAs, and 320 to 400 hours for the PSRs.
Can I ask a question real quick on that? And if not, I'll bring it somewhere else, but just out of curiosity, is there something in the policy? So if you are sick the day before or day after the holiday, you don't get your holiday pay, is that incorporated in there? Because that sometimes is used.
Yeah, no, not that specific, but what we did put language in there that said inappropriate use or trending, and we can look at that.
So informational only, but I think the majority of staff and leaders really look forward to having something that we can have some accountability with, and expect and anticipate our staff to be there and ready to serve our community. Page. Just wanted to note, ending the year, all the grant awards that we were able to secure. So thank you, Crystal and her work to secure all those grants. Biggest couple of ones were with legislative VAR, support the surgical services remodel of $600,000. And then working with Patty Murray's office to get $2.5 million to support the reimbursing grant for the general surgery and orthopedics remodel. So we are still waiting on that one for federal budget stuff to happen over that before we can get that.
And I saw that the federal stuff signed it last summer had some money for rural hospitals. I heard Washington State now knows what they're gonna get, which is approximately 180 or 190 million or something.
182.
Do you know, can our hospital expect any slice of that, or what's your instinct?
Gonna give you a little.
Oh, no, wait till you come up. I didn't know it was taken care of, because it happened just yesterday or whatever. So I don't want to be like Jason and steal your thunder, so.
I think I just stole everybody.
Yeah, Jason's report's gonna go last from here on out.
Not a bad idea. Other thing I just wanted to note that it doesn't steal anybody, so maybe Ron does.
Yeah.
I wanna coordinate to have our chair and vice chair meet with Hospital District 1, Hospital District 2's board. So chair and vice chair of District 1 and District 2, we want to coordinate to have and at least do an annual time to connect and talk about our shared interest.
Meet at the Indian John rest stop.
Andy to help us coordinate.
Yeah.
That's the last.
Yeah, that'd be good. Let's work together to figure out a time that works for both groups and get together.
That's important. Thank you. All I've got in my report.
Any questions for Jason? All right,
I'll take the time to talk about our telemetry system though and update. So we've had a telemetry Philips monitoring system a little bit unreliable over the last couple of days. It started with a help desk ticket and got escalated up to Jeff and Holly to get Philips on the phone and get them out here. Happy to report we are back to admitting. We're admitting, we feel it's reliable now. Last night we opened the incident command to work through, understand exactly what's going on, what patients we have. We stopped admitting patients that would need telemetry, and then we didn't expect that we would have, I think it was 6 ER patients come in that need telemetry all at once. And we also didn't have much reliability for transports to get those patients out, and also receiving facilities. So not great, but most facilities in Washington are at capacity right now. So we can't get them out if we want to. Most facilities are full. We got a couple out yesterday, one out today. We staffed up Medic 1 with a 3rd car to be able to take some first outs. I stole a Ron. Talked to KVH, they are trying to hang on to their staffing and to support us with a little more support as we navigated this.
We staffed up with a nursing staff too,
Yep.
to help cover and, be available to run into rooms if things were, so we really rallied as a team to cover the needs of our community. Meet it with the.
And one of our nurses is married to a Philips research and development engineer. And he was able to come right over, well, he worked with Philips first to get the green light, came right over and he was rounding today and got us back online.
do you know how many people we didn't have to transport out, who we otherwise would not have had to transport out during this process because of this problem?
I don't think we transferred anybody. I think we took everybody that we needed to and made do and accommodations until we could. So
Good.
I think we did a great job.
They held in the ER, so it was
Yeah.
only med surg and CCU that was experiencing that. So we did have a lot holding in the ER.
So when you said we had a couple people yesterday, or it sounded like we were shipping some people out, and I'm just a little confused as to what you were saying versus what Holly just said.
They scheduled ships anyhow.
That needed shipped out, yeah. And then the 4 telemetry, we were holding 4 telemetry, trying to find placement, but couldn't. So they're staying in our ER.
So we just found other solutions without shipping them out,
Yes.
because statewide hospitals are kind of maxed already. No one had openings for our patients. Okay.
And I just admitted 2 of them a couple hours ago.
Yeah.
ICU.
It's a new topic. Are you done?
Yeah, please go ahead.
I was been trying to think about how this, it's not really a question, it's more of a comment, I guess. When we talk about new services, sometimes we're talking about services that the community had that are just new to KVH, like when it went from Ellensburg Pediatrics to us having pediatrics, or we had Cascade Foot and Ankle, and now we're having podiatry. But there are also some services that are completely new to the community, like urology, I think is new to the community, right? And also vascular surgery, when we didn't have that, we got that. So,
There's
Um,
Yakima urology.
oh, okay. I mean, it's all good. That's all interesting. I guess, I'm just, sometimes in my own head, I try to kind of distinguish those two because, it seems, I mean, it's all impressive. It's all great. I'm glad that KVH is taking these things on. But sort of, the new services that have not previously been available to people in the community, it seems like those are things we should sort of shout from the rooftops. I mean, the other stuff's really good too. Again, not trying to downplay that, but and molecular, or sorry, nuclear medicine too. That's new to the community. We've never had that before. Anyway, I just, again, it's not really a question. It's just in my head, I usually try to distinguish between those things. And so it seems like we really want to publicize those new services that they're not used to our having.
Yeah, and some of it, Cascade Foot and Ankle is a good example. They have been practicing up here for like 27 years, Dr. Hartley, Dr. Johnson. But then most of their surgical and stuff does go to Yakima, infusion care and stuff goes to Yakima. So they still had that service of your seeing patients, but they will get much more service all located here and have to travel less.
Right.
So there is a couple branches of it there. And
Right.
Pediatrics we took from Dr. Herman, which I think was 1.5 providers, and we now have 5.
Right.
So
Yeah, so I mean, by our taking it on, we can sometimes often increase the amount of that service that's available. And then, like you said, there's this sort of middle ground where with Cascade Foot and Ankle, they can get it done here. So it's kind of a new service, but not, anyway, it's, I guess, again, it's not much to say about this, just when we talk about new services, there's sort of, variations within that. Anyway, that's it.
Part of, as we look at projects, whether that's a strategic project or a project that Naomi is working on, part of that's built into like our smart sheet project management is marketing. And so that's something that we work with Crystal on. Okay, do we have this? Do we have this? What else do we need to get out to the community? And so and then on their end, they have a whole kind of checklist of what they do within their department to be able to market these like new things to do to make it exciting for the community.
Yeah.
So it's good to know what it looks like on yours. Yeah.
Oh, that's great.
Yeah.
All right, thank you.
and we do always look at partners too. I think we had audiology a few years ago, potential interest, and we just further partnered with and reinforced our audiology practice in town. So it's really been in partnership with these. Obviously, Cascade Foot and Ankle, it's been a couple of years coming with first bringing their service under KVH's umbrella up in Cle Elum for the last couple of years, and then to Lower County as well. And Yakima Urology has really struggled to continue to bring their physicians up here. And all of their surgical and stuff goes back to Yakima. So having that all up here and be able to seek that care up here will be good for those patients.
Sure. All right, thank you.
Anything else from the CEO report?
That's all I got. Thank you.
So moving on to human resources, Janine.
We'll have better recap at the next board meeting for year-end metrics, but suffice to say our workforce metrics are holding steady. Recruitment knocked it out of the park. 2025 was kind of our year of stabilization in terms of recruitment, and I think they did a phenomenal job, and we'll have their dashboards to illustrate that next board meeting. But both Heather and Kat are operating at the tippy top of their productivity, and just great, exceptional conversion rates in terms of the number of applicants that they are managing and then converting to actual hires. Just outstanding rates by industry standards. And Kat achieved her national certification this last month. Very proud of her for that. That's not an easy thing to achieve. So that was cause for celebration. Kyle, with his work on the students and job shadows, highest numbers we've seen for that. And as we all know, that's where you start to cultivate those relationships that then convert to hires later on. And we're starting to see the fruits a little bit for that, because that's the long game, right? You're playing years out, and we're already starting to see folks who started out as a student or came through as a job shadow and then are now converting to employment. So that's wonderful work there. And yeah, I just any questions on that? We'll have actual dashboards to.
Any questions for me?
And we had union negotiations went very well with WSNA. Was very happy with that. We had wonderful participation with Danny Crawford and Cody Staub. They just brought some real-time, real expertise to the discussions. And we made a lot of language changes that those contracts, just that contract in particular, had not been touched for some of the language in there, just had not been updated for 2 or 3 contracts. So it was really nice to it took a little bit longer than we have historically spent with them. That wasn't because there was any sort of drama at the table. It was very collaborative, very cordial. We just spent a lot of time really parsing out, getting the language up to snuff and getting it, and to reflect the way that our directors need to manage and the way that the union's comfortable with. So very happy with that negotiation. And Teamsters just went lickety split for that, which is pretty typical. So very happy with the contracts.
These are 3-year contracts?
Yeah, we started, typically, I think the last few contracts with WSNA have been 3 or 4 all-day sessions, and we plan to have longer, more involved work going through the language of this one. So we actually scheduled 7 full-day sessions from the start, and we finished in those full 7 days at the last 15 minutes. So it went really
right
well.
up to the wire.
Yep, went really well. Like Janine said, everybody that put in all that work, and WSNA had the right people come in and give the right staff come in and give their perspectives from home health or the various areas. So just a few things wanted to run through, and then wanted to ask the board for a motion to authorize the board chair to sign and ratify these. And both the contracts have been voted on, ratified by the unions. On WSNA is just some ideas or information on some of the language changes, like bolstered up per diem shift requirements. So a lot of staff, we have per diems, but didn't feel they're coming in to pick up enough shifts to be particularly helpful. So it has some requirements where they have to come in enough to stay on employment status with us and pick up shifts. A little bit more clear language around when they would receive a 15% per diem stipend, whether because sometimes they can be employed in a clinic and get benefits there, but then per diem for the hospital, there is some confusion in language there. Salary step progression, so having 1-to-1 experience credits with the nurses, so they have 12 years somewhere else, they can have 12 years of experience credit here. Premium differentials, a significant change that we made was on night shift, making it from a flat rate, I think it was $4.50 an hour for night shift work, to being 12% of their base wage. So it scales with their growth, because what we're experiencing in night shift is we'll get the entry level nurses that come in, but we need the seasoned, more trained nurses to be able to train them. So once somebody, often night shift is that foot in the door, and then once there's a day shift open, they'll jump up to their seniority. So we're really trying to encourage those people with more experience to stay on night shift and help train up their incoming staff. Vacation time, we removed 16 hours from their vacation bank and put that over from sick time and moved it over to vacation bank, because people are using their sick time, whether they ask for time off for a vacation, they get denied that, then they just call out sick. So it's moving it over to vacation time where we can at least plan for it in the scheduling programs or protocols. And then just a lot of various language that was not very clear, whereas I would have like MedStar CCU doing something one way, ED doing something another way, FPP doing something another way. So everybody's administering the contract in the same method. So they did a lot of red line, a lot of change to this contract. I feel like we're in a really good spot to do that cleanup work that was much needed. And Janine was able to find a new labor attorney to help us navigate that. And our attorney and WSNA's attorney just were really rock stars in partnering us through this.
They're across the board raises?
Yeah.
How much?
8%. 8%, 4 and 4.
844.
Yep.
We are very fortunate. I'm just saying, I think it's a great contract.
And Holly was able to jump in the last two negotiations. We appreciated her timing. Was awesome to get Holly in here and to jump right in. And she's went through quite a few negotiations in the past, so her experience there last couple of years.
Do you need separate motions for these two contracts or one motion?
Please.
Okay. Anything else before we approach that topic?
I move to approve the WSNA contract.
I have a motion and a second. Any further discussion on WSNA contract? Hearing none, all in favor, say aye.
Aye.
The two vote aye. Anyone opposed? That motion passes. And we have the Teamsters contract, same situation.
Do we discuss this first or no?
We can discuss it, or we can also discuss after a
I
motion.
just wasn't sure if there's presentation on it or not.
Oh, no, there wasn't a lot of language changes needed for the CS contract. I can tell you it was 3 and 6 for the non-cert and the certified in year 1, and then a 3 and 3 in year 2 and 3. And that was pretty much just economics, really. One of the reasons why I think it went so fast.
Yeah, they're really good partnership with their team. Carl, union rep, and then I think they have the whole CS team in.
Yeah, it was kind of fun.
Yeah.
It
It was really nice to connect with them.
Yeah.
I'll move to approve.
And one thing unique that we did in that Janine mentioned, so if they're certified, their economics went up 6%, and this one non-certified was 3%. We're trying to emphasize our techs to become certified in that area.
Yeah, that's an incentive.
Yeah, that's great.
And they also, yes, it's a big.
We have a motion by Erica.
You know, Terry? What? You want to make a second?
Sure. I'll take a second on that.
Okay, motion and second. Any further discussion? On approving the Teamsters contract? All in favor, say aye.
Aye.
I too vote aye. Anyone opposed? That motion passes. All right, anything else, Janine, or some on that stuff?
No, yeah, thank you to the whole HR team, Janine, for.
That's a lot of hours went into that, I know.
4 contracts this year.
Yeah, well, and I cannot stress enough, the frontline staff, the nurses, the Cody and Danny, just everyone, it was a really good, robust back and forth. And it felt like, I thought the attorneys, their commentary back and forth, it was just a very focused discussion. And there's been a lot of kind of stuff going on outside, but in the room, it felt very good. It felt very focused. It felt like we could disagree in a way that was not antagonistic, but more, really more about putting together a contract that made sense for both sides, which I really appreciated.
I am very glad that the stuff going on outside did not affect me.
Did not.
And we actually got some good traction where we're about 8 months ago, I'll talk about the commitment to coworker cards that your team was working on rolling out.
Yeah.
We got their buy-in through this as well.
just part of our whole kind of culture building. We had a bit of a blip with this commitment to coworkers. That was kind of a grassroots movement that started in some other areas, and we had a bit of a blip with that with our WSNA members, but we came back around, had some discussion about that, and actually came up with a document that everyone can agree on. So we're rolling that back out. We are doing that on the heels of some of these policy changes as well. The attendance policy, one that, you know, is hitting pain points on both sides of the equation. So I think it's great that we're able to come together to come up with a solution that everyone wants: accountability, right? And then on the heels of that, we've got some compassionate accountability training. It's going to be a workshop for all of our directors as well to try to help get some footing and foundation on how to manage through that. It's a paradigm shift that we're dealing with that we know is going to cause some angst among the groups. And so we want to equip our directors with some training and support to be able to navigate that in a way that they feel comfortable with and confident in how we're kind of managing through these changes. So I'm just very excited about that.
The little blip was a cease and desist letter, but yeah.
Yeah, it's all right. We got yours.
All right, moving on to operations, and I just want to start by saying on behalf of the board, Holly, how much we've appreciated your leadership and the stability you brought to the nursing group as the chief nursing officer. So again, thank you for coming in December and spending the holidays here. So Holly, what do you have for us today?
I won't belabor all the stuff that's already in here, but I did want to call out that we have started executive rounding this month. So the whole executive team, we've divided them up and divided areas that they will focus on rounding in at least once a month. And that is something, you know, Jason and I rounded on New Year's Eve and also New Year's Day with Crystal. We took some, really appreciate Crystal and her team and the work that they do, but took some sparkling cider, non-alcoholic, around to people. We did go up to Clay Elm on New Year's Day, and they were very appreciative at that clinic that we rounded with them. So really trying to focus on rounding consistently. That's what I've been doing a lot of in the nursing units. Really trying to engage staff, you know, develop that trust with staff that seems to have been missing for a little bit. So we've seen some fruits of that labor. Today we had a meeting with, it's called the Nurse Clinical Practice Committee, where it was just fun to see the engagement and excitement of our clinical clinical excellence department. And Mandy presented some information about our harms rate and looking into data, and they're excited about being involved and engaged in it, which is really, I think, something
I'm like,
something we haven't seen.
yeah, it was really incredible.
So just working on those things. The clinical excellence piece is a big piece. We have developed a nursing a needs assessment where we're sending out to the nursing staff to find out what their needs are by the end of this month, and also starting a charge nurse class and also a preceptor class. So just trying to one thing at a time. And we do have a plan to have a fall prevention committee again, starting at the end of this month. We've had a lot of falls, and so really have been partnering with Mandy on looking at those things and how we can, you know, involve the frontline staff. So anyway, that's all. Any questions about what was on this?
Any questions from the board?
Not a question, but a comment about what Jim's up to in food services. I'm Rib. Pretty awesome. And then it's an automated smoothie machine. I was really sad. I still haven't gotten over not having Sally in the hospital. The salad making machine. But the smoothie machine sounds pretty.
He's very excited about it. He's talked about it. The other thing that
Weekend about that.
I think we're very excited.
yes, he did get some feedback from some some of the difference about opening for lunch at 10 instead of 11, and he is making that happen starting next week. Jim works really hard and works on the holidays when he tries to support his staff to be off because they have small kids. So one thing I really appreciate about Jim.
Leader, that's
Yeah.
nice.
The ice cream sales are down since Julie left, though.
One person support of the.
They're definitely down.
Anything else for us then?
No.
Moving on to Chief Ancillary, Rhonda.
My report's on page 32 and 33. I think Jason has shared most everything with you already. Probably my only update would be under the Midtown Depot. That project is going really well. We did have to extend out our move-in date to February 23rd. That was because we had a delay in getting some interior doors. So we set it for the 23rd to get the equipment. And now we have our doors in sooner than anticipated. So darn. We are on that Friday before going to be moving some of the desks over out of family medicine Cleolum because I have some staff that will be working and that will be good for them in engineering. Then on the 23rd, that Monday, the therapy staff will meet the people who are bringing in all of our gym equipment and make sure they get it placed in the right location. And then on the 24th, the Department of Health will do a walkthrough with us to make sure we can have occupancy. So it's coming right along. It looks beautiful. Crystal did get the coming soon banners up.
Yeah.
It's dark when I drive by. So it's looking great.
So you're happy then with it is a good example of the quality of KVH and so forth.
Absolutely. It's beautiful. And the architects and the construction have been wonderful to work with.
Good.
Just really, really impressed with them.
Excellent.
But I'll take any questions that you have on anything else.
I know that this isn't your jurisdiction, but you are the liaison de facto for Upper County. Do you know anything more about whole health?
They're really close to being able to get occupancy in the event.
Okay.
Yeah, I don't have a date, but I feel like I pester them at least, every other week to find out a date for them. But it's happening.
That's good. I'm glad they're
It is, yeah.
successfully moving forward.
We're also trying to help them with some grant work as well to hopefully further support their capital investment.
District 1 and District 2 are both supporting that.
And District 1, District 2 are,
Yeah.
yeah. I get some legislative to support them as well.
So the turnover in phlebotomy, so we do not currently have any sort of training program. People have to come here already with the experience, training degree, whatever it is.
Yeah.
How feasible is it to create a training program? I mean,
Well, we need to be staffed before we can have people to train them. So that's kind of the rub there. But it is just such an entry level position and we do see such turnover that I feel like once we get there
Yeah.
and train our own. Another piece of it too is just training on the KVH culture and our philosophy of care. So a lot of times we're bringing in people that have trained at another organization and it doesn't necessarily mesh with what we want for customer service or teamwork or kind of our core values.
are these the people that draw the blood or are these? And so is that considered like an entry level position?
Yeah.
Because I want people sticking a needle in my arm to be well paid. So this is just industry wide. This is how it works and so
We'll
forth.
have to talk to Jennifer about the wages. No, just phlebotomy.
I had a bunch of students last quarter who were really cool.
It's actually a shorter program than the MA program.
Oh, much, yeah.
MA has
weeks.
a specific phlebotomy program as well.
Yes, and MAs can draw blood,
But you don't
but I
have
can
to
tell
do
you
it.
with my lab background, your phlebotomist, that is their focus for that training. Your MAs have a very, very small, I would say they do maybe 25 sticks as part of their training.
Okay.
So where your phlebotomists are talking at least 100 on their rotation.
Okay.
So
I can
different.
tell you, our MAs did a lovely job. I volunteered to be stuck. A couple of them, and they did great.
That's good. But our medical director, Dr. Lynham, she's on board with us bringing the program here too. So we have her.
Sounds like
support
it'd be a
and
great thing to grow into when we're ready.
Yeah.
So, yeah. Good. Any other questions for Rhonda? Thank you. Chief of Clinic Operations, Stacy.
So I am not going to talk about podiatry since we covered that. But I will mention Family Medicine of Ellensburg. We have our first certified nursing assistant working in the clinic ever at any of our clinics. So we were really excited to bring this person on board. The difference is in integrated behavioral health. We don't do vitals for most of those patients. So it really is a different skill set we need. And when we were using MAs to room those patients, a lot of the MAs are like, I'm losing my skills. I'm not doing vaccines. I'm not doing other injections. I'm not helping on procedures. So we were seeing a lot of turnover of people going, no, I really don't want to do that. I want to get my hands back on patients. So we think this is going to be a really good move forward for us in the integrated behavioral health program. And then just a comment about Marcella. Marcella worked with us as a medical assistant. She was one who really, really enjoyed the integrated behavioral health program. And the team in Cleellum and even Marcella are just really excited to have her come back as a clinic nurse. So it's good to see the growth. And just we've had a lot of people that have moved through the MA program into nursing and even into PA school. And I can answer any questions you have.
Any questions? All right, hearing none. Thank you. Appreciate it. Next, we move to medical staff, Chief of Staff, Dr. Hoppy. Don't see her there. Is there anything we need to cover for her?
Since we didn't have MEC last month, so yeah, she may not be on anymore.
Okay. So we'll assume there's nothing there. So Dr. Thomas, Chief Medical Officer.
Thank you very much. My report begins on page 37, and after Jason's report, I too am out of thunder. But I would like to point out two things. One is that if we include Monday looking back for the last month and a half, we will have 5 new provider starts, not inclusive of Dr. Carden starting in podiatry, which is very exciting. But I'd also like to highlight the incredible annual accomplishments of the Medical Staff Services Office, highlighted under the column from Shannon Carlson's report there. You'll see a total of 7,000 online DEA verifications, 6,000 license verifications, total of 700 hospital affiliation verifications, and 370 National Practitioner Data Bank queries to support a total of 22,000 verifications that that office was responsible for last year. That's an incredible amount of work that reflects the incredible work the recruiting department has been doing, bringing all this new incredible talent for our community. That's all I've got. If there are any questions, I'd be happy to entertain this.
Any questions for Dr. Thomas?
The 4 total joints that Dr. Longo did, those were on different patients or one?
I sure hope so.
Thought I'd check.
Our goal is to increase Dr. Longo's throughput. He has high aspirations, and so far we have been able to expand to 4 in a single day, but we'd like to continue to push the envelope and maybe achieve 5 in the near future.
It's ambitious.
So, yeah.
And Holly's team's also working with him and the team to start looking at outpatient total joints where it's appropriate as well.
Yeah.
Any other questions for Dr. Thomas? Thank you. Appreciate it. All right, moving on. Finance, Chief Financial Officer, Jennifer.
Hello, my report starts on page 39. I won't talk too much about it, except to point out my revenue cycle effectiveness index still needs some work there, but the 94.7 is accurate down in the narrative. I messed it up for you. So just to kind of landing on month over month trend, just showing you year to date how it's going, but the status is how it is right now. So red would be more than 10% off our target, and yellow is up to 10% of target, and green is good. So pretty good all in all. Inpatient stays have been down a little bit. And I was talking with Celeste today about that, and I think it could be a difference in observations and inpatient from last year to this year, so it's kind of looking into that. Anyway, so like I have been saying, that revenue cycle effectiveness index will really be a consolidation of all the things the revenue cycle is looking at, and we'll weight that, and that's what you'll see. So that's still will be some work. Any questions about that at all? And then I could move to the exciting part about the rural.
Any questions before we get to the exciting part?
I think it's all exciting, actually.
All right, tell us about the exciting.
Balance sheet, here we go.
The balance sheet is not that exciting. So, I did want to point out, there was a note in Wisha about some charity care rulemaking that's going on. We don't know exactly what they're trying to do, but the Department of Health is really famous for going after rulemaking instead of actual legislation. So we really Wisha really watches what they try to do kind of under the dark of night. So I'll be in a meeting next week to see what kind of that is all about.
Because
I
I think,
imagine it's not good.
I think we approached 3.8 million or so in charity care this last year.
Yes.
So it's risen pretty drastically in the last 2 or 3 years.
Yes, and we increased it a lot for next year too, just to be.
On the budget for, yeah. And so do you believe the rulemaking that's potentially going on could hurt us more or tighten things up and say like, you really shouldn't come from out of state to get free care?
It really doesn't help us.
Okay.
So they're the ones that did the geographic thing, and we'll see.
Okay. Now we need the happy news.
On a happier note, I told you that the collaborative had been working with the DOH and Wisha and all the partners on that, what's it called? Yeah. Rural
Rural health transformation.
Yeah.
Grant.
From the BBB H1. And that they were asking the collaborative for input on how to write the grant. So every state had to write a grant for this money. Up to $200 million was the yearly amount, and they did get awarded, the state of Washington, $182 million. We have to move quickly, so we don't expect that we know much of anything until April, and then it has to be spent by September. So we're trying to really set ourselves up to spend it quickly. One of the fun parts is that the collaborative was awarded $6 million. And that's just for the collaborative hospital. So on networking and fun stuff to do. So we have a lot of pull there. There's also a big chunk for workforce, which we'll also be able to apply for, and technology. So that's really exciting. If we spend all the money, we will be up for money again. So it would be the same amount for 5 years. They're threatening that if you don't spend all the money, then they are not going to give it to
Well, I
us.
can help you with that.
You can.
Do an RFP.
But anyway, it's nice because the collaborative will be in charge of $6 million of those dollars, so that all the hospitals will enjoy that money. So yes, that was exciting. Okay. Anything else I wanted to talk? Maybe. It's your capital listed there, but nothing new this month coming forward. Anticipated to come is there, and then kind of talking about Radio Hill and my recurring suggestion for a master facility plan. I think I'd really love to get support of the board to move forward on that if we could.
Yeah, we could do that.
It's $67,000.
Yeah, so Jennifer's been working with a architect and engineer, JJCA. They came in and looked at our ER and FEM at where the board offers us to engage with them to look at those two areas. And we want to have them look at all of our facilities. So we have a budget of how much from them?
67.
67,000 for them to come in and really do a really high level look at all our facilities and then a high level look at our empty property over there as well.
The urgency is the infrastructure, right? So the boilers, the chillers, the roof. And they'll come in and bring a mechanical engineer first and assess all those things. And then also the land and what's the feasibility there. So I'd really,
And so the deliverables would kind of give us where we at with each facility we own, what to expect, things on the horizon.
and growth and what should we be kind of.
Would this include the houses?
Yeah.
So all property owned by the district?
This is a different group than the group that did it like 7, 8 years ago.
Yeah, KDA has done most everything before. So it's a different group. They're based in Nashville, but they do quite a bit of work up in Washington. Jennifer's worked with them at Whidbey and the public, so. And they really specialize in master site programming.
Yes, for critical access hospitals, so they just really do, and we can have them do a presentation to the board, they'd be happy to do that.
At the end of the process?
Or before, next meeting.
If we engage their services, how long do we think it would take based on what you described?
I've been kind of gearing them up to think that I was hoping this was gonna happen in January or February, and they come out for a week and then they present something. Stacy, and I don't remember if Rhonda was there when they did Cleellum. After they've been here for the week, then they sit down and present their ideas, and then they go off and do the actual plans and a budget and all the things. So in the budget, you'll see a breakdown of their budgets from Cleellum and from sort of some short-term phasing of solutions for the ED downstairs that won't break outside the walls, but will, we think, help them down there. So anyway, I just
You support it?
it's really important. Every time somebody wants to move, I go, yeah.
So for the board, is this a decision you feel you can make with the information you've heard, or would you like to hear from this company present their proposal before we decision?
I'd love to hear just a brief proposal or the other one, mistake.
And I do have their statement of qualifications that I can send to y'all too.
Okay, yeah.
That's fine.
Yeah. It's fine.
So the consensus is before we vote on spending the money to hear from them first, so the next available board meeting time slot, can you think you can arrange that?
I can.
Yeah. Jason, do you have any issue with that as a way to?
No, not at all.
Yeah. Okay.
Okay, back to where I was. Just sort of my outlooks, and we can move on to in the financial statement,
Sure.
unless anybody has questions about.
What page are you on?
I'm gonna move to page 42, and we can just kind of talk about some key statistics, just overall. Really, the one that sticks out in my mind is the surgery, the patient days for swing bed, and Holly and I've actually talked about how we can get the swing beds moving a little better. I think it's a really great program to have. And then our case mix, you can see our patients are sicker, but they actually aren't staying too long. 3.4 days is our length of stay, which needs to stay under 4. So that's good. Our surgeries are down a bit, a bit in minutes, but not so much in procedures. So I think they're just doing faster procedures.
What hips are there?
Yeah, turnover is a lot faster. Multiple reasons. So a dog goes from one room to the other versus waiting. So
Bouncing one.
turnover is a lot quicker, long goes for a day, and then 2 days ago. So I will.
Then hospice, I think we kind of have some plans in our mind to talk about how we can tackle hospice maybe. At least on the financial side. And that's about all I wanted to point out there on that. Unless anybody has questions on the statistics, we'll just go on to the dollars. All in all,
What page?
oh, now I'm on 45.
Thank you.
All in all, our, this is only November, so we have one more month, and in 2 weeks, you won't have an actual financial statement, you'll have a draft, because we like to keep it open as long as we can. But for now, we're over budget in our revenue, by $5.5 million. By the time you get down to total operating revenue, it's only $1.1 million, and not only, but, that's because we still have a pretty conservative allowance calculation on there. And we'll know more once the cost report's done, but I think our interim was pretty close, so I don't expect a huge sway one way or the other. And then expenses are also over budget by 3 million, but I think last month I pointed out that the net revenue was 1%, and so also are the expenses 1% over. Let's see. Oh, that's about all I have. I think we're coming in really close to budget year to date, and our net income at only $120,000 under budget, and that's pretty good.
Whoever
Good
did
job.
that budget.
Whoever did that budget was amazing.
And so this is November, so we'll have one more to close out the year.
One more, yep.
There's still a chance for you.
Tighten that up a little bit. Yeah.
So on to balance sheet, which is, that's not a lot happens on the balance sheet. Cash and current assets are a little higher than they were last month. We did pay down some debt. $1.2 million debt service payment.
Do you recall when our next balloon payment is that 2027 that we have?
Yeah.
Have to start
And
thinking about.
we have maturities covering that, so. That's about all I have to say about the balance sheet, I guess, unless anybody else has. And then you can see where all the cash went during the year. We had actually brought in cash from operations of a little over $13 million. And spent it on a lot on property, plant, and equipment. And you'll see even more suggested spend on your budget next year for property, plant, and equipment. Otherwise, we have ending cash on hand of $3.3 million. Investments, we've got 166 days. Any questions about those? Trying to look back. And then you have your AR days. It just is pretty much covering right where it has been. They have started working on the credit balance policy and a small balance policy. So, so you'll see some of those 365 days and more going away as we move them through the systems. That. And what I had to say about that, on the investment sheet, you can see that our maturity amounts for 2027. I don't have them added up here, but that adds up to just a little bit under the $10 million that we have coming due for balloon.
Is there any chance we'd want to refinance that rather than cashing it out?
Maybe. I think it kind of depends on what we decide to do with that building. So, any questions about that? Is that my resolution? And if not, we can go on to the budget.
Yeah.
So I understand we're missing a couple of sheets in the packet maybe for the budget.
Yeah, so we just.
We have them now.
It's a trending.
Okay. So my narrative there, basically, I'll just run down the proposed budget income statement if that works for everybody else. And you can see on the revenues, we have an 8% increase over this year's annualized amount. And that's really basically a 3% volume increase and then a 5% overall change in our price in our charge master.
And so our charge master, did that 5% take effect like on January
Yep,
1st?
January 1. And we really looked at every department and some got a big bump and some got decreased and, so the net change was 5%. Then our deductions from revenue, we have it set at 45.62%. That's a little less than it has been, but with our coffee goals, I think we can get there. We do have financial assistance. You'll see it 52% increase over this year's annualized amount.
So that'll be over 5 million next year?
Yeah. Yeah. I hope it's not.
Gives you something to talk about when you visit Olympia.
Yeah. Yeah.
You have to bring these real numbers to them.
That's as long as we don't do a good job in keeping everybody on Medicaid and all the things and plan to do, but there's gonna be some work involved there.
Yeah, I think before that new legislative expansion in 2022, we were like 800,000.
I did put that on there for somebody who asked me. Charity care financial assistance on the year-over-year financial operating indicator. Sorry, I didn't point that out. I went back to 2017 and showed you across this line 26 across the board how our charity care has grown a lot. In 2017, it was $1.1 million, and in this year we expect it to be about almost 3.6 million. Let's see. So we did adopt a legal budget, and tonight we're just amending that legal budget with the resolution, but I didn't. Well, I did. I guess we don't do that. This is not something I'm used to doing, is amending this. So my apologies that I didn't put the legal budget down here, but we did pass a legal budget at 3% net operating margin at 4.96 million, and we ended up at 4.94 million. So we had a great budget cycle. I think Scott and I and James all separated out the cost centers. We met with every manager and director and went down the line, and this is where we ended up. And so are there questions about the statement? Just a little bit that I wanted to point out was the cash flow and financial position in my budget presentation. And with budget, we are projecting 175 plus days cash on hand at the end of the day. Our operating cash flow would be 23 million. And I am budgeting $19 million for capital improvements and investments. And that is includes debt service and our maturity on investments. You'll see there on the next page, we have 4.56 million maturing against a debt service of 3.2 million. So what are we gonna spend the money on, or what am I proposing we spend the money on? The Radio Hill renovation, we expect to be about $2.8 million. And that will be done probably Q3 2026. On that note, the property line boundary adjustment has been filed and signed and it's done. So
Hey.
glad to hear about that. The ED short-term expansion, that's keeping it within the walls, but sort of lightening the load for them, getting the beds out of the hallway and doing some other things to make it a little more livable for them. That's a $4.4 million project. And the LM optimization, of course, that requires HD2 input and consideration, but that is $2.16 million, and that's really just the first phase, and that's getting PT rehab moved out, behavioral health kind of pod put in, and that's the major thing that they're talking about doing up there. In 2027, and that's $2.16 million. And then we have a remodel of the X-ray room for neurology, and the MAC is coming in about $400,000. And then we have our other, projects, the roofing repair of $3.2 million, boiler projects between $1.5 and $2 million. Our data center relocation of $250,000. And then the one unknown right at the moment is generator optimization in the hospital and also at Radioville. So what can I answer questions about that?
Those items you just listed, we primarily would just pay cash for them. We wouldn't be taking out any.
That's correct. And we could, but
We could,
also pay
but
cash.
the current plan is to. Any questions about the report for the budget?
Clear. Yeah, it's clear.
Just call out a note on our non-operating revenue line. We've really had almost no tax levy income before, so I see a huge jump there from usually running about $2 million, which is investment income, up to 8.3 million. So that's about 5.8 million from our constituents. So just a shout out to our community for voting for us and the people in this room voting for us and advocating for that levy win.
I think we may want to look at when property tax notices go out and maybe time some of these things we're expanding to match that. So again, people can see we're reinvesting.
Podiatry is one of them. And urology and those programs as they start coming online, we're matching those.
Like some people are gonna feel like a drunken hangover when they see what the property taxes are. Or it's gonna be a line item for some people, so.
It is.
Yeah. So the last page is just some risk management and mitigation. If you have questions about that, that's just what could happen to my budget. But I think everybody did a really great job and we didn't even have to go back and ask them to cut anything. So that's extra special.
But I really appreciate the efforts your team put into this. I know it's a lot of work.
They're a good team. Good team. So
What do you need from us?
So with this one, the board always has to approve our operating expense for the year. So it authorizes operations to spend up to that amount. So you're really approving that total operating expense for the year. And that's why we come back at the end of the year for exceeding that, for spending more than the budget, and ask for a lift on that allowed amount as well to spend. So just a.
Is this 26 one that we're making a motion on?
So then our resolution is for 164 million budget.
Just a resolution to adopt the amended budget as presented.
All right, so anyone on the board has any questions or is ready to make a motion to approve resolution 2601? I would entertain it when ready.
Move to approve.
Okay.
Yeah.
Motion by Matt.
Yeah, I approve it too.
Is that a
Are you seconding? Second by Terry?
Yeah.
Yep.
Okay, motion second. Do we want to wait for Bob to return real quick or? There he is. All right, so any further discussion on approving this resolution 26-01? Hearing none, all in favor favor of approving the amended budget for 2026, please say aye.
Aye.
I too will vote aye. Anyone opposed? That motion passes.
Thank you. And thank you.
Anything else from the finance side that we should know about?
Unless you have a question, let me.
Okay, thank you. Then that is done. So then we are moving on to new business, which is a review of some board policies. So it's a new year, and I think it's always a good time for the board to take a look at some things that we do and ask ourselves, is this the best way to do it? Last year out of that, we ended up with Spotlight, which we've been doing. It seems like people are enjoying that. So I had a few questions I just wanted to present to the board and take feedback from anyone here who wants to offer feedback. One thing we've been looking at, Mandy Weed sent us all a notice recently about our public records and open meeting training. I don't know if anyone's had a chance to actually do that yet. I had the opportunity to do it. It was, again, it's a good refresher. It makes you think about things related to running public meetings and the proper way to do things. And so that led to some thoughts that I just wanted to ask people. In no particular order, we currently record, we lost Nasser. He was the sole survivor. So we currently record our board meetings. And again, I'm trying to remember when this came about, if it was COVID, or I can't remember if we did it before COVID or.
Recording them in 2016, didn't we?
I remember.
Whatever it is, again, but the question we need to ask ourselves, is it what's best for the hospital? And when you research a lot of the similar type hospitals in this state, most of them do not record their meetings. And, there's a couple, there's obviously pros and there's cons. And I just wanted to see if the board members had an opinion on this and if that led to any sort of change. But one thing to think about in today's world, especially with the advancement of AI and whatnot, is a lot of these things now are scraped. You put something online, it's pulled into a system and they look for useful information and whatnot. And you remember, we're a standalone public hospital. Everybody that makes decisions about how this hospital is run is sitting in this room. And that's a real advantage in today's world. A lot of hospital systems can't say that. So, but it also means we're somewhat vulnerable to much more powerful entities and whatnot. And so my approach to thinking about it is, we obviously want our community to be able to know whatever they need to know about what we're doing. None of this is to hide anything from them, but it's to say these outside entities that can sit halfway around the world and grab our video, it's transcribed, it's all sucked into this system. Is that helpful to us versus the potential damage that can come? Maybe another hospital wants to see what sort of doctors we have here, and we talk about them, we praise them, we do things like that. And it's like, oh, we should recruit that person. So again, I kind of live in a paranoid world. I spent 5 years in intelligence overseas. So I'm always kind of looking at, what are the things that can damage us that damage us more than help? So I just put out to the fellow commissioners, since it's not by state law that we have to do it, most similar hospitals do not do it. I know we do it because we do it, because that's how we do a lot of things here. It's because it's the way we've always done it. Is it worth a discussion to make any sort of change about recording our meetings? And I put that out there. And if anybody has any thoughts, I would love to hear them.
I guess I'd have to hear more about what the risks are. Maybe I'm just naive, but it just seems to me like out of transparency. It's a public meeting. So, if somebody really, we have to, do we have to be on Zoom? Do we not have to be on? I don't know. If we're available on Zoom and, I don't know. It's just, I guess I'd need to hear more about the risks.
And that was going to be my follow-up. Would we prefer to just stick with Zoom so it's live in the moment? So if anybody wants to tune in, they can hear it, but we don't archive it. So anyone literally in the world can suck it up and see what we're up to.
So I did pull the Rural Collaborative too, and most have a Zoom option available, but only for very few record. So.
I don't know. So it's a public meeting, so anybody can see it. Even on Zoom, people can see it. So I guess I'd need to hear what the additional risk is to having a public meeting available to anybody now in the world in real time, what the additional risk is to having it available to everyone in the world in a week or a month. I guess I just
I think John's point might be that it's persistently out there instead of them having to maybe schedule to capture whatever nefarious things that they would want to do. I personally would need some time to, process those pros and cons, and I hadn't really thought about it in that light before. I recall when we first instituted this, it was definitely due to transparency, and I do feel strongly about that. So I have to have some convincing in the opposite direction for me to feel like we should let go of it.
Yeah, I like the transparency. I mean, I think all of us have enough information out there that they can grab it. If they really want to get to it, they can get to you. So from a Zoom, not sure if what they could glean anything else unless, so there's an outburst or something like that.
Terry, do you have any thoughts?
Well, I think we really should have a Zoom and a recorded meeting. Because when I was on the governance board for Wisha, they talked about it a lot, and everybody in our county can hear it. And I've had a lot of people tell me that when this meeting's recorded, they look at it maybe a few days later, so they can read and hear about the public meeting. So I think it's very safe. But the problem that it sounds like you're talking about is that since it's recorded, people even over in France or place like that could actually listen to it because it's recorded if they knew how to get the access to it.
There's some thoughts to think about.
Yeah, well, again, it's the beginning of the year. It's an opportunity to revisit why we do something when most other similar entities do not do it. So that was kind of the impetus for that discussion. Connected to that is the Zoom part. Do we want people who participate in the meeting to be required to be here in person versus appearing on Zoom? Again, just, if anybody has an opinion on that, I mean, I like it when people are here in person. It's much easier way to communicate with them, read the body language and things like that. I know sometimes it's not convenient for them to be here, but my theory on that is for anyone who can't be here, ignoring the commissioners, have someone else on your staff attend in person. It gives us a chance to meet them and hear their ideas. Very few things we're doing are so critical. Only the leader of that group could pass that information along. So again, just food for thought, how people feel about Zoom versus requiring people participating in the meeting to be here in person. Again, unless there may be like a contractor or somebody who's in Spokane and giving us a bid information or something like that. That would be an exception.
I'll do some homework too. We might have to have a Zoom or digital option available to call into. So I know when COVID started.
As I know, it's a newer law.
COVID.
Yeah, my interpretation was it's not a requirement.
Okay.
But I'm not a lawyer. I just play one on TV. So, another thing, doing that, the public records and open meetings thing that they talked about are the minutes. And my takeaway from that is our minutes would be considered too detailed. The recommendation for these legal organizations that do the training in Washington State is that the minutes should really only capture decisions, not what people said. Ollie said this or Janine said this. Because they said since it's not a transcript, it's easy to misrepresent somebody by summarizing what they said rather than them actually saying it. And it's not required by law. So they're basically saying there's no upside to making your minutes too expansive. Capture the legal decisions and as you progress through the system. So again, I asked the board members if they have a feeling about this. If you reviewed the two meeting public records and the Open Meetings Act tape, they talk about it in there. So again, I don't know if anybody has any opinion on the minutes, if we want to do a more condensed version or do status quo.
I mean, I agree with that. I like the idea of just saying, I mean, it wouldn't have to be exactly this, but discussions,
Mhm.
right? Discussions. Period. Makes it easier for many.
Make it easier.
Yeah, but you know, I mean, we can record that we discuss things, but we don't need to record the specifics of the back and forth. So I agree with that.
Well, if we circle back to the first thing, which is a recording the meeting, there is that reference anybody can always go to if they want to know the more detailed, fleshed out version. But the legal documents required by the state of Washington become a little cleaner and less subject to, I didn't really say it that way, and we've had that over the years. There's been time where I said, I don't feel that reflects exactly what I said.
Fair point.
So.
Yeah, I'm fine with that.
So it sounds like. Go ahead.
We need to be official for that, or is it just Mandy, please
Lean on the joke.
be
Very excited.
Oh,
she was.
I agree with Matt, what he just said about that.
Okay. So do you feel we need to do anything official other than we're just kind of letting you know this is what we're comfortable with?
I think this is good. I'll
Yeah,
try to do this for the next set and send them to you and Terry.
Christmas.
thank you. So another thing that was talked about is what we publish related to an agenda and a board packet. We need to publish an agenda, need to provide it at the door, put it online or whatever. The board packet, to the best I can determine legally, is not required. And again, it goes back to the same thing, what information we're putting out in circulation for anybody in the world to scoop up. Name of our providers, all the doctors are listed in that. If you go over a 2-year period, you'll see every provider who works for this hospital listed in that board packet. Just picking real simple examples. Again, I'm paranoid, Matt is not paranoid, so we got to find the middle ground.
Well, wait a minute. Middle ground may be where I am, but I mean, it's people can look at our emails if they want to.
But they have to put effort into it. That's often the threshold of effort determines what information somebody seeks.
Well, I mean, so just as an example, we don't include in the quality report now the sort of minutes from the QI Council. It's just a summary. So I think as long as people are aware that this stuff is going to be publicly available, that I don't really see the problem. I mean, people can see what providers we have here by looking on the website. So anyway, to me, it's another transparency thing. I like the packet. I mean, would the idea be that it wouldn't even be available to people who are here, or the idea that it wouldn't be
available to people here, doesn't it?
Not necessarily. The agenda has to be, but not the board packet.
I mean, I like the idea of giving all the information we can to the League of Women Voters, for example. So I wouldn't want to cut them up. I like the idea of letting people know what we're doing as a public hospital. I don't know.
We don't differ in that. I'm just saying it's presented during the meeting, not on the World Wide Web where anybody can grab it. That's the only difference. I want people to know it, but I want it to take place in this room.
As a citizen and a community member, I have access to other packets for other entities, and I would be really frustrated if I could not access that online. Are you talking about having it available and kept online for like recent posterity versus long-term?
Once it's online in some computers forever.
Gotcha. Yeah.
Again, I'm just trying to understand just to make sure what we're doing is what we actually intend to do.
As a public hospital district and, with a publicly elected board who are representing the community members who, not all of whom are here, I like the idea of erring on the side of too much information for especially members of the community and not worrying so much about someone on the other side of the globe sort of looking for stuff. I mean, I guess I'd rather risk that. I'm not sure how big a risk it is. Maybe Jeff has an opinion, but I'd rather risk that than have some angry community members saying like, what's going on? And I could Just direct them, or I could tell them, I don't know.
And nothing stops anybody who comes here for these meetings from uploading it on their own server and here world, here's KVH's.
Again, they have to put effort in to do that. We're not just gifting them.
I appreciate you bringing all this stuff up. I mean, I think
Yeah, that's what I'm
things
talking
to
about.
ponder on, and definitely we should bring it up next.
Yeah, and I don't disagree with any of the feedback. Again, I just, we've had a lot of time since the last meeting, so it festers and say, what should we talk about when we get to January? So
There's businesses too, where their whole business is they grab this data and they're not overseas. We were targeted by one. Where they grab data, do public records requests, and then turn around and sue us. So, and we got that 2 years ago. AWBHD is going through right now.
Can
So
you
what-
give
what-
an example of what that might look like?
It was related to a public records request. They asked for something and then they twisted it and used it against us. And
they try to get paid off, basically, is
they
the
did.
goal.
And they're successful.
Yeah.
Based on what we've published?
No, this one was not from what we.
They wouldn't have had to do a public record request for this stuff since it's out there. Yeah, I mean,
But it's.
people are gonna make the effort.
Getting that.
I was just
Detail
wondering
to
if-
have available to them, the more targeted their request can
That's-
be. And the same thing is true with social engineering. The more details available to the party who's making that request, the more carefully they can craft their message to try to gain access.
Isn't it market concerns too, that people to the south of us could also use information in these board packets to?
I didn't want to say that because we're being recorded, but that is one of my main concerns.
All right, but competitors looking at us and saying, what can I get, what can I glean from your board
What our
packet?
strategy is.
I have global politics on my mind, just trying to figure out what.
No.
I mean, I want everyone in this community to be able to know what we're doing. What I want to keep is everyone else out. I'm trying to find a balance with the complications of how quickly things go through the internet and whatnot. That's all I'm trying to do. Because I also feel we're very accessible. Somebody emails me, wants to talk, I'll meet them, whatever they want to do. So we're not reclusive. We're just gifting all this material with zero effort to people we don't know, and we don't know what their motives are. So unfortunately, solving that cuts out the decent people who just are curious, what's KVH up to? They have no alternate thing, but unfortunately, the world currently is filled with people with ulterior motives.
I don't know if this is a good analogy. Okay, but just like we'd rather let 10 guilty people go free than one innocent person, I'd rather risk nefarious actors getting hold of this than to cut out community members who really deserve the information. That's my opinion.
And who are strongly financially supporting us now.
I mean, it's a public hospital district. They can see my emails. They can see everything. I'm an open book. We're all open books. So they can do public records requests. The idea that we're going to make it a little harder for those people to get it at the expense of people who want the information and don't want to have to jump through hoops to get it. I just don't think it's worth it. Me.
Any other thoughts from the commissioners on any of these topics? So speaking about emails, so I wanted to reaffirm that for the commissioners particularly, any official business should always be conducted through the official hospital email address you're assigned. Nothing on your personal texting, things like that, personal email addresses. So just, we've been, I think, really good about that. Just it's the beginning of the year, just reaffirming, let's make sure we do that. If we feel texting is a way to do it, then I would push to say the hospital, it'd be nice if they gave us like an eSIM or something for a second line that is owned by them, even if it's in your phone that, for public records. So
Partitions it out, so to speak, that partitions that out.
it's this whole separate number. It's most phones these days can easily do a second eSIM.
Like Google Voice.
Geez, give me a burner phone, will you?
Okay, but again, just keep doing what we're doing, which is use email if we got to communicate, and again, but avoid obviously any sort of serial meetings or whatnot. Oh, and one of the big takeaways as a reminder from the public records and whatnot is, like if I need to communicate with all of you about something, I can send an email to all 5 of you. You just cannot respond to it. In other words, you can't begin a discussion, but I have to maybe give you information. This is going to happen.
One way.
Then you have it, but do not respond to it. Just assume you saw it if because I sent it to your email address. So just keep that in mind, but you'll see that when you do the thing. All right, so enough of that silliness. So if we can have slide number 1 up now, I'm so excited because we worked on making sure this is.
One.
All right, and then, okay, so this is our current calendar. The gray third row there is today, so January 8th, 2026. It has been 35 days since our December 4th meeting, and the December 4th meeting was 42 days since our October meeting. Now, going forward, the thing that really got me thinking about this is, as I'm sure all of us are aware, 2 weeks from now, we're going to be right back here. And I'm hoping everybody has a whole bunch of new information to give us. And then we get into 35 days, 28 days, and then you get down, if you scroll down just a little bit real quick, as we get near the end of the year again, we get 42 days between a meeting, and then we get 21 days between a meeting. So I was just thinking about that. I was on in 2015. I've been on since 2019. Fourth Thursday of every month. That's when we have our meeting at 5 p.m. Lock and go. But no one can explain it. Why is it then? So I asked myself, why is it that? Is there any other day that might be more logical? And so looking at the calendar, I thought, well, what if it was the first Thursday of every month at 5 p.m.? And so if you can bring up chart number 2, and so scroll up just a little bit. Okay, so the gray is still today. And so if it was the first Thursday, since last Thursday was January 1st, it would have bumped to this week anyway. So coincidentally, both these meetings, fourth Thursday or first Thursday, end up on the same day. But now when you go backwards, instead of being 42 days, we would have had a meeting on December 4th, but the previous one would have been November 6th. So it would have just been 28 days. So as you can see, as you go through the year, it alternates 28, 35, 28, 28, 28, 35. So the only real conflicts now when leap year is January 1st and July 4th, as far as I can tell, as to every 5th or 6th year would land on the first Thursday of the month. And so what I like is for like staff members in particular, I hate thinking in 2 weeks, you got to go through this again. It without having a reasonable amount of time to build up exciting stuff to talk about. So I just wanted to ask the board members how they felt. Are we locked into the fourth Thursday, or with something like the first Thursday, which gives us 28 or 35 days year round? Be more. You're gonna crush me, aren't you?
I'm just gonna offer one small observation.
Yeah.
We've been talking a lot about how long it takes to prepare a report that summarizes the last month's work.
Mhm.
And it is felt that generally that report can't be prepared by a lot of our departments until at least the second week of the month,
Mhm.
which means that the report that we would present to you on the first week would actually be the preceding months, not.
Which I note on here. Yeah.
I'm just observing that there would be.
But often it's only 5 days different than it is now.
Sure.
So again, it's not like it's 2 years later or something, but I do hear you. It's that balance. And I especially thought for finance, it would potentially give finance that extra week to sometimes not be so rushed because there's so many numbers to put together. It's not perfect. I'm just asking, is it better than when we get to November, December, especially? I hate how it just jumps all over and we get these huge gap and then a very tiny gap in January to get the 2 meetings in January. So
What about second Thursday?
well, it's just getting to Dr. Thomas's point. How far do you want to get from when the information was created? If you're doing second Thursday, are you then telling everybody you need to do last month, which might be only 8 days ago when it ended? Thursday. Or the fourth Thursday?
Yeah, let's go.
That was uncalled for, so.
I get what you're saying, and I think it's worth discussion. However, if people in this room were like me, I have designed my life around these Thursdays, and there are some very concrete things that I've put on other Thursdays now, which might be problematic for people. Maybe it's not, but I suspect that it might.
And this could start a year from now. I'm just pointing out, I'm trying to smooth out the distance between meetings because the current version we have as little as 14, as much as 42 days between meetings.
And is it just Thanksgiving and Christmas we're trying to deal with?
Well, then New Year's this time really did it as well because it's 1 week. It was the trifecta this year.
Yeah. I mean, I don't have a preference.
I don't either. I think we're keeping people here pretty long tonight.
Yeah, I don't have a question either.
What if we think about this in ruminate us independently, and revisit it.
I only speak about this the first meeting in January. You won't hear from me again for years.
You can email,
Then I won't be present, so you won't hear from me at all a year from now.
you should email this out to everybody.
Who is everybody? That's
Well, it's the board.
But don't reply.
Don't reply.
I think they see it. I mean, I'm not getting that warm and cozy feeling like when you said we have extra money.
You needed help.
You didn't start with, I have exciting news.
Price assigned for that budget.
We'll do it when we probably break for executive session. So, all right, well then, as noted, I've taken up too much time, so that'll be the end of new business, which means we are on to executive session. What do we need for executive session tonight?
I would love if Dr. Thomas and Holly would hang around. Jennifer, I told you you're welcome to, but you didn't.
I don't know what that means.
You know the topic, but you're welcome.
How much time will we need?
Let's say 15 minutes.
15 minutes.
I think we can.
So let's take a break till 8 o'clock,
Maybe that efficient.
and then we'll do executive session from 8 to 8:15. Dr. Thomas and Holly is who we're asking to stay.
Thank you, everybody.
Thank you, everyone.
Amy.
What's the executive session?
Thank you.
Thank you.
Paper is man, stop.
You need to stay executive session.
RCW. RCW, what it is? For RCW.
RCW 423.1101. This is for evaluate qualifications of an applicant for public employment.
Guess
what we are?
Is there action?
No.
No action.
Thank you. Right, it is.
Thank you.